Hello, check.
हेलो। हेलो टी। आइए डॉक्टर साहब।
हेलो। Rhinoplasty workshop at Dr. S.P. Dube's Divya ENT Center, Bhopal. It is my pleasure to be here after invitation of Dr. Dube sir. Uh, Actually, I came to Bhopal for the first time, and this is a really nice city, city of lakes. Also found lot of trees, so green cover is absolutely more in this. After Bangalore, I think this is the greenest city in the India. So Bangalore is also green city, but Bhopal is nowhere less. So I am very happy to be here with you all. So good morning, and we have just induced one case. So before the attendance increases, the YouTube share link is already shared with you. So I will explain the photos and everything till the delegates are coming. So till that I am just infiltrating this case, so
Yes sir.
that the whatever tachycardia happens after the infiltration, that will subside at the time of beginning of the case, and also the local anesthetic will work. So I am just infiltrating the case and handing over the patient to the assistant for painting and draping. So and we will take the incision till the number of people are more.
Right sir. Sir, kindly tell us what infiltration you use for
Yeah.
your rhinoplasty
Yes.
cases.
So what I use is ropivacaine. Uh, Ropivacaine is, I think, 0.2% ropivacaine is used, and I used freshly prepared ropivacaine with adrenaline. So in a 20 ml of ropivacaine, so this is the vial of ropivacaine, and in the 20 ml of ropivacaine I add, so 20 ml is taken in this vial, and I add 0.2 ml adrenaline, 1 in 1000. So that
Sir,
makes 1
sir,
in 1 lakh.
sorry to interrupt you. Dr.
Yes.
Kirti Yashvir is here.
Okay.
She is our Gandhi Medical College associate professor,
Yes.
and she is very much interested into rhinoplasty
So I,
work,
good
and
morning
she
madam,
is
and I
today's
welcome you all.
morning moderator.
Yes, I
So she
welcome
will ask
moderators.
you questions
Yes,
regarding
yes, yes.
infiltration and everything.
No, no problem.
Good morning,
So,
sir.
good morning, good morning. Welcome madam for this knowledge sharing.
It's a
So,
pleasure to see you, sir.
yeah. So, I use 1 in 1 lakh ropivacaine freshly prepared, no preservatives, nothing. And we just infiltrate with 3, I infiltrate with 3 cc syringe and 25 gauge 1.5 inch needle. So,
Yes.
first infiltration is always at the radix, then second infiltration is along the nasal bones and the lateral wall of bony nasal bone on this side. Third infiltration is on the dorsum in the middle, and fourth infiltration is in the area of the tip through two domes and columella. So the big needle is taken and it is just passed in the plane, and you just go hit the bone in the premaxillary area, and while infiltrating come out. So you infiltrate almost 2 ml in this area, so that erects this area, and also it takes care of the bleeding in this area. So this infiltration is very much essential when you are elevating your skin cover and you are taking the incision, so that the oozing will be less. Yes, the tachycardia happens definitely initially, but it settles. And also I never infiltrate on the nasal septum. So infiltrating on the septum causes lot of tachycardia, increase in the blood pressure, and it stays longer. So I infiltrate only on the external nose and the skin cover, and never on the septum.
That's a
Now,
very interesting point, sir.
yes. Then another infiltration, after the external infiltration, I infiltrate in the scroll area. So this is the hairy part of the skin, you can see well.
Yes, sir.
This is the hairy part of the skin of the vestibule.
Yes, sir.
Then this is the septum which is deviated on the left side. Photos I will discuss later. And you are infiltrating in the scroll area, just 0.2 ml at each side at 3 spots, and also on this side at the scroll area. Now why at the scroll area? Now what is scroll area? Scroll area is the area where you see the when you are drawing, आप जब नाक ड्रॉ करते हो किसी की पेपर के ऊपर, so the curvilinear line which is drawn on the nose, so this is the scroll area.
Yes, sir.
This is the scroll area. Scroll area is the junction of upper and
lateral
lower alar cartilage.
Yes, sir.
So in that area I always infiltrate, because it will not obscure your incision, because I don't take marginal incision, I take incision at the lower border of lower alar cartilage. So that area is not masked, also it is very nearer, so the infiltration will reach up to that area, and while taking the incision there will not be bleeding. So once this infiltration is over, I always put fresh adrenaline platelets that will decongest the nasal mucosa.
So overall, you've put about 5 ml of
No, I infiltrate around 10 ml
10 ml.
total. Yeah, I prepare 20 ml, because if at all it is required, you can infiltrate still more.
Yes, sir.
I prepare 20 ml, but out of that 10 to 12 ml is required maximum, not more than that. So this fresh adrenaline cotton is placed in the nose.
So this is what diluted saline
No,
adrenaline?
no, this is pure adrenaline.
Pure adrenaline, 1:1000.
Yeah, 1 in 1000, undiluted, unquantified. So the adrenaline will prevent entry of adrenaline in the circulation. Once the congestion occurs, the further adrenaline decongestion occurs, vasoconstriction occurs, the further adrenaline entry of adrenaline will be prevented.
Yes.
So it works. This is topical adrenaline, so this will not have much effect on the heart rate and the blood pressure.
So any points on how do you fix the tube?
Yes. So you can see on the external camera.
So that part we are not seeing. So
No, I'll tell. But can you see on the screen tube?
So, no, sir. Only the now we can see. Yes,
Yeah.
sir.
So usually I use flexometallic tube or a south pole tube, whatever is available.
Yes, sir.
So south pole or flexometallic tube is passed, and the curvature matches with the lower lip and the chin, and it is always taken in the midline,
Okay,
and
sir.
it is fixed in the midline. Also it is supported laterally, so that there should not be tube drag on the nose,
Yes,
and
sir,
tube
yes,
should
sir,
not be
sir.
mobile,
That's a
because
that's
head movie will be moving lot of times during the surgery, but tube should not move at that time. Tube should remain in the center. I also do loose packing. It is a cuff tube, but still I do loose packing, because lot of blood goes into the nasopharynx
Yes,
and the
sir.
oropharynx. So I do loose packing of the throat, tube fixation in the center. Then the eyes are in the eyes I put lubricating eye drops, and if you see, I apply horizontal tapes,
Yes,
not the
sir.
vertical tapes.
Okay.
See, the function of these tapes is to prevent the action of levator palpebrae superioris. So to counter the action of levator palpebrae, it is always better to apply the horizontal tape. So taping is done. Also, if the eye is open in between the surgeries, you can put the saline which you are using for the wash. So
Yes.
eye care is also very, very important during the surgery. So can I go ahead with the yeah, we can do the painting and dripping.
Yes, sir.
So can we go ahead with the discussion of photographs
Yes, sir.
and
Please, sir.
views, various views?
Yes, sir.
पेन दे दो जरा. Okay, so these are the, actually 6 photographs are required ideally. 6 views are required for any rhinoplasty patient. Now photos are required mainly for two purposes. First is the documentation and second is plan. I always say first documentation. See, surprisingly, we have memory of only 3 days of our face. See, I look into my face in a day for just 6 minutes. If I calculate throughout the total time for which I am looking at my face is 6 minutes. Average, worldwide average is 6 minutes. So I will be having very short memory of my own face of today's. Then you all have seen my face today for more time than me. So the memory of face for that individual is only for 3 days, and that is proven. So after 3 days, that new face becomes yours only. You have that much memory. So it is always better to have documentation. People do tend to forget their original face, number one.
Totally agree, sir. Totally
Yeah.
agree.
So number two, in the selfie era, they take a lot of selfies, and the selfie is absolutely picture which is not true.
Yes.
So the true picture always, see, I am not looking at your face from such a close distance, anyone. So ideally we are looking at someone's face at least from the distance of 5 to 6 feet or 2 meters. So if I go so close, that is called as fish eye effect, and the fish eye effect should not happen. So fish eye effect happens with the mobile camera. So to get the good picture, good view of the face, the photo should be taken in an ideal setup, that is a studio setup. Now the studio setup you cannot create everywhere. I am coming here for the workshop. But the newer cameras are really good. Only thing, they should be used wisely. So I have taken these photos today morning only, but see, it is looking at it has been taken in the studio. Now what is the scenario, how I take the photos? Now the photos are taken in the daylight, number one. The daylight is coming on the whole face, and you can see the reflection in his eyes, reflection of the daylight. So the whole light is totally enlightened. Then there should not be top light or the shadows or the lateral lights. So whole face is lighted with the sunlight from the front, or you can use some flash, portable flash, but it is better to use the sunlight. Then the background should be uniform and little bit faint. So either you can use faint green or blue color background. So there should be uniform background. Then the angulation of the face should be scientific. Now this is, so 6 views are the front view, basal view, helicopter view, right lateral, left lateral, and right oblique, left oblique. So these are 7 views. These are taken: front, basal, helicopter, right and left lateral, and right and left oblique. Now in the front view, when you are printing the photos, the front view should cover whole face along with neck, both eyes. So the whole face is visible in all the 3 parts, and also the ears are visible, eyes are visible, and everything is proportionate. It is not too much zoomed out. So this is the first view, and this is the photographs which we want in OT in front of the surgeon. So you should keep eye on these photos, and what are the changes which are happening after your every step, you should keep in mind, and you should compare with the pre-operative photographs. So this is the first photo, and you can see in the first photo you can see all the 3 parts, one third part of the face, and then vertical 5 parts, that is lateral, then eyes, nose, again the left eye, and the left of the lateral part of the face, and also the ears. So all these parts are visible. You can compare in the first part, the nose is deviated to the left side, to the right side, and the septum is like a C shape. If you can see here,
Yes,
the septum is like this. So there is a gross deviation of the nasal septum on the left side. Also the dorsal aesthetic lines are deviated. Now what are the dorsal aesthetic lines? Dorsal aesthetic lines are the lines which are drawn, or these are called as brow tip lines. So this is the nasal tip, this is the eyebrow, and this is the dorsal aesthetic line. So these lines are interrupted on this side because of this curvature of the septum. So in the front view you always see all full face, then the dorsal aesthetic lines, these are seen. Now in the basal view you always see at the base of the nose both cartilaginous base bone width and the bony base bone width is seen. So in this case the base bone width, the bony base bone width is normal, it is not at all excessively projecting. Also the cartilaginous base bone width is little bit more. So how to calculate the base bone width is mid-canthus and the base of the ala. Draw a line, whatever outside is more wide, whatever inside is narrowing. So define the cartilaginous and the base bone width, and the lower base bone width is more, but it is because of columellar retraction. If you see in the lateral view, you can see a little bit columellar retraction, and the columellar retraction is because the caudal septum is not there in the midline, it has shifted to the right side. Because the deviation is on the left side, the caudal septum has come to the right side, and that's why there is a little bit columellar retraction. You also see in the lateral view, the nasolabial angle is acute.
Yes, sir.
Yeah, so this is the acute nasolabial angle, tip is little bit drooping, the cartilaginous base is little bit wide. Also in the helicopter view you can see the same deformity. In the lateral view otherwise the dorsum is straight, the running point of the nose is normal. Now what is running point of nose? The nose starts at the upper eyelid crease. So this is the upper eyelid crease. If you draw a line, so ideally nose should start from here. There is a little bit low radix. Now in Indian population we see lot of low radix, while in the Greek or Greco-Roman nose you will see really high radix. So here in Indian nose we will find little bit low radix. The running point of the nose is little bit low. So we may augment some part of the radix, so that will give him a really good dorsum. Then also I will take care of this acute nasolabial angle. So this is the ideal tip, this is the ideal running point of the nose. Draw a line, straight line, so the dorsum should be straight, the nose should be longer, and the projection should be better. So these are the goals which we want to achieve. So yes madam, go ahead.
Sometimes in the dorsal view you were showing, sometimes they have facial asymmetry as
Yes
such.
madam, second case is of facial asymmetry, that's why I am not discussing in this.
Okay.
But this patient is not at all having facial asymmetry.
Okay.
So facial asymmetry is clearly visible, and that's why I have taken the full face photo. It is clearly visible in the area of malar eminence, then in the area of ears.
So
That's
that's what I'm asking, like what would you compare to see that there is no facial asymmetry? So
at the outset, if the nose is, nasal axis is deviated to one side, see it is axis deviation. If if you draw a straight line,
yes sir,
which is passing,
through
dissecting the philtrum,
yes sir,
and you just compare on both the sides. Also you just palpate on the nasal bones, and you can compare the length of the nasal bones. So on the concave side the nasal bone is longer, while on the convex side it is not, on the shorter side it is normal. So in the facial asymmetry, one part of the face is normally developed and other part of the face is less developed.
yes sir.
So the less developed part of the face is flat, but flat on the malar eminence, but on the nose it is longer.
Yes.
So because of the axis deviation, there occurs axis deviation, and this part becomes longer. So second case is of facial asymmetry.
Okay,
So draw a line passing through both the domes, philtrum, midpoint of the lip and the chin. Draw a straight line and just compare on both the sides.
yes sir. Okay sir.
And sir, why you emphasize taking photograph
Yes,
with ear,
yes,
both the ear? What
because
is the
the
use of
whole
ear?
face should be visible,
Okay.
not just the zoomed out picture.
So this you have taken with mobile camera or with
Yeah, this is with the mobile
DSLR?
camera. No, no, this is with the mobile camera.
Okay, and sir, at approximately just you said about 2 meters. So
Yes,
you keep that distance that much?
yes, I always stand at the 2 meters and make it
Okay,
2x or 3x zoom.
okay, sir.
So
Thank you.
then you get the really
Because
good picture.
most of the time it's not always possible to have a DSLR camera,
Yeah,
so
most,
it is
see,
mobile only
in my
90%.
setup, in my own hospital only I use DSLR with the studio lights.
Okay, sir.
So that creates the exact picture scenario which you want.
Okay,
But
sir.
at least you can mimic. And
Okay.
another thing for documentation I told you,
Uh-huh.
see whatever I always take of thousands of rhinoplasty cases I have done till today, I have documentation of all the patients.
Okay,
And wherever I go, I always insist to the surgeon where I am operating to send the photos at set intervals. That is pre-operative, on table, then at the end of 1 month, at the end of 3 months, and at the end of 1 year.
okay.
So at least, if at all the patient comes at the end of 2 years. So by the end of 2 years, whatever reconstruction you have done is final, whatever edema that has settled, so whatever reconstruction is accepted by the body of the patient. So these intervals are very essential, and the patient's face and the nose keeps on changing. So
Yes.
patient is most unhappy between the period of 1 month to 3 months,
Yes, sir.
because there is a reduction of differential edema. So edema will not settle at one go at all the places. See, the edema settles for the first time on the radix. So see, throughout the day we are standing. So
Yes.
the edema settles more in the tip and the supratip area. So the tip and the supratip area is stiff, is rocky hard, is not mobile. So during smile also the nose is not mobile. So from initially when you remove the plaster, the patient is very happy because there is no edema, nothing. Patient has just come out of the surgery and he has seen the change in the face. Now by the end of 1 month to 3 months, differential edema reduction occurs. There are some symptoms. Patient feels there is no pain, but the patient feels I am not feeling my nose. The patient feels he is not aware of his nose. Like that, different complaints come from them. So all these complaints should be considered. And after 3 months, they really become happy because the tissue becomes supple, the nose becomes mobile, the hardness reduces, the edema starts decreasing. So then the patients become happy and then they never come. So my routine experience is they always come complaining some or telling you some or the other complaint by the end of 3 months, but after 3 months they just send other patients to you because they are happy. So that is also, then I do call them, tell them to otherwise I will not do your surgery. So the patient referred by the happy patient, I tell that patient to bring the one who has referred you to me, and then I get the photos. So by the end of 1 year, you definitely, I see that I get all the photographs.
Yes, sir.
But the patients do come for the follow-ups, and the documentation is very important for your presentation, for the development of your own techniques and everything.
Yes, sir.
Sir, kindly tell us about your VTOM which you have with you.
Yeah, this is the actually.
एक मिनट, सामने से हटो boss.
Yeah, this is the stand, and there is a VTOM scope. You get a VTOM scope. So VTOM scope is really good attachment, but VTOM scope suddenly there is no competition to Zeiss, to stores for VTOM scope.
Yeah.
So the stores is the only manufacturer of VTOM. VTOM is the name given by stores only. So the stand you can make it from anywhere. Amazing Surgical, Mumbai makes the stand, or I think Narang from Delhi makes the stand.
Yes.
So making the stand is not the issue. The stand is fixed to the table. It is articulated arm. The cost of the stand is around 60,000 rupees. Really
Right.
good stainless 304 grade. I am using this arm for last more than 10 years. Nothing has happened. But instead of VTOM scope, what I did is, like the endoscope, I have devised one attachment. So this is the attachment.
Yes, sir.
Okay.
Like the endoscope head, there is no lens, nothing, this is, it is hollow, but it holds the camera.
Very nice.
It is used as a camera holder.
So who manufactures it? You yourself or
No sir,
somebody
Optofine
else?
makes it for me.
Acha, up to fine.
Sir, it is nothing, anyone in the town who is having that CNC machine can make it, sir.
And you
It
see
is
the
made of
picture,
aluminum.
Kirti is how good.
Yes, sir.
It is
Vitom
made
is
of
not there.
aluminum, but it makes life easy, your demonstration becomes better.
So you can have Vitom in 25 lakhs and 75,000 you can make everything.
And this is made in some 500 rupees, that's it.
Right. We welcome Dr. Namdev, who is a previous editor of
Yeah.
IJLO.
Yeah.
He's a senior ENT surgeon from Sihor. He is here.
Okay, welcome sir.
Sir, anything about pre-operative counseling apart from what
Yes,
you said?
pre-operative counseling is really good question. So never always listen to the patient first. So why he has come to you?
Yes, sir.
So see, don't interrupt him. Number one, first listen to him. Whenever he stops, always और कुछ कहना है क्या, और कुछ कहना है क्या, उसको बोलो कि वो कुछ कहना चाहता है तो. First listen to him, what he wants from you actually, what are his complaints of his nose, what is likes and dislikes. So when he starts explaining, you will come to know the psyche of the patient, number one. So whatever he is telling, are you finding the similar signs in that patient? That is, he is saying the deviation of the nose, he is saying about the nasal obstruction, he is saying about he is sleeping on one side only, whether he is saying about snoring, then whether he is saying about breathlessness, use of decongesting drops. So that tells you that the patient is in really need of the surgery because he is having breathing difficulty.
Yes.
Then number two, you find the anatomically nose is good, nose is normal functionally, but he is having some saddle, some irregularities which are correctable. So if you find them, which is so your examination points and the patient is what is telling, if it is matching, then there is no need to go for psychological assessment of the patient. But your clinical examination, patient signs, symptoms are not matching with the expectation and what you can deliver. Expectation of the patients and what you can deliver out of the surgery, if they are not matching, then definitely you need 2 or 3 sittings counseling. Let the patient go and consult other person who is doing rhinoplasty. So then he will come to understand that all the surgeons are saying the same thing. So never, unless you are convinced with the patient's disease and what you can deliver, unless
Yes,
you are
sir.
convinced, don't take a decision of the surgery at the outset.
Yes, sir.
So if the patient is having a short nose, saddle nose or traumatic deformity, then these patients you examine and what you can deliver, what are the graft material, what are the approaches. So everything has to be discussed in detail. The photographs are to be taken, the photographs of previously similar surgeries, what you have done, they should be shown to the patient. That gives the confidence and the patient start feeling better because, but I never give the computer simulation. Now with the AI, I have found that the patient, though I was not giving simulation, now the patients are coming with the simulation with the AI. So they feed, now it has become so easy for them, they feed their photos and the AI tells what are the flaws in his nose and what can be done for the better nose. So patients are definitely coming with the AI, but I always see that I get those photos, I tell them to share those photos to me on my email and I tell them that this is not possible to do with the AI. See, this is the camera trick, the AI has done the reconstruction, but in actual this kind of reconstruction is not possible on the face because there is nature in between which is taking care of the healing. So surgery is one part, healing is altogether different ball game, healing, infection and expectations. So the patient, I was never sharing the simulation to the patient. Now the patients are coming with the simulation. I tell them you share those simulations to me, so that becomes a record on your side, and you write on that. Even though the simulations are there, such kind of result is not possible or cannot happen because of so and these reasons. So it is not that all the patients are mischievous, but it is always better to speak lot with them.
Yes, sir.
So can I start with the case now?
Yes, because you should
Yeah, it is
start.
9:45.
We have good number of delegates
Yes.
already here.
Yeah. हाँ you देना. So wherever I go to the workshop, I always go with my instruments, own instruments, and my assistant. So the assistant is most important for arranging all the things, taking care of your instruments, and see what in my whole the journey I always my assistant Shivaji is always accompanied by me. So that makes your life easy, and you are making a scenario which is similar to your home setup. So as if you are operating in a home pitch. So your own instruments, your own assistant makes you feel little bit comfortable.
Yeah, because
Yeah.
we welcome our esteemed Dr. Sudhakar Vaidya.
Sir, good morning.
Good morning, good morning. How are you?
Yeah, fine, sir, fine.
How you find the place? And
Sir,
Dubai's
beautiful.
hospitality.
The place, the people, the city, everything is fine.
Yeah. Please, we are watching you.
Yes.
I think Kirti madam is a moderator for this session who has joined late. I think she will explain you what has happened up till now, how he has infiltrated everything. Dr. Kirti madam will tell.
Sir has used Rupivacane for infiltration. He used he says about 10 ml, and he infiltrated at the radix and at the lateral wall, and then at the dorsum and at the tip. From the tip to the base with Rupivacane, he does not infiltrate on the septum. And sir also told that he puts plain adrenaline packs in the nasal cavity. Plain micropore is put on the eyes, and the eyes are kept open while painting and draping. And also the endotracheal tube is fixed in the midline so that there is no drag on the face. Then there was a discussion about the photograph, that the photograph has to be taken.
So shaving of vibration is the first step. Yeah, you get the hair removers. Yeah, now it is almost 15 lakh. 15 lakh. Yes. That one endoscope is costing 15 lakh rupees.
With the stand, sir, or without the stand?
Yeah, that comes with the stand. Again, sir, stand is not that costly. It is too wet. और छोटा बनाओ, एक के 6 बनाओ, 5 या 6 बनाओ. No, I use loop.
टेबल थोड़ा ऊपर उठाओ. नहीं हे छोटे कर जरा, निम्मे कर, दोन कर एकाचे. I use 2.5x loop
Okay, sir.
and I use Kim headlight.
Okay. So the so loops, the loops have your power added on to that, or with the
Yeah,
specs separate.
fortunately I don't have any spec, I don't have any distant number,
Okay, sir.
but because of the age I have near number.
Yes, sir.
So
So
just
Vikas
2.5x
is a
loop.
so Vikas is a regular gymmer. Yesterday he has operated one case in which he has to take rib graft. I think it almost went on for 5 hours, but after 5 hours he was very agile and healthy. We were tired. And in the morning also he get up early morning and came in time. So Kirti, are you using this kind of knife only, or you use some V cream which are used by our endoscopic ear surgeons? They put a plate of V cream like an French hair remover cream. So that is without doing any trauma, you can remove the hair. It was very effective. We have seen in Mubarak's workshop. You put in the ear, two plates are there, and subsequently there is no hair. You can see very well with the endoscopic ear surgery.
But what about any reactions or no reactions, sir?
I think no reaction because we have used in 4 or 5 patients. So I suggested Vikas also that you can
Yeah,
use
definitely
indoors.
I'll start using, sir. So the incision is taken along the lower border of lower alar cartilage. So you can see this the elevation, this is the lower alar cartilage, and it is exactly in the junction of hairy and non-hairy part of the vestibular skin. So the incision is never taken in a single stroke, it is taken in 3 parts. So as as taught to all of us have been taught by Gubish, we go from lateral to medial approach. So the columnar incision I take at the end, but lateral incision I always take in the first. So this is the in the right nostril I am taking incision along the lower border of lower alar cartilage section. You can see the cartilage getting visible. You can see this white cartilage.
Yes, sir. Yes, sir.
Okay. Now the second part of the incision is taken along the columella in the skin crease, taking care you are not going too deep.
Yes, sir.
And the middle finger of your left hand is supporting the skin on the other side. So this incision is taken and join these two incisions. This is the third step of the incision.
Yes, sir.
So incision is taken on one side. Then my hand may come on this side, so just bear with me. Section karo thoda. So this is again the lower border of lower alar cartilage on this side. Can you just see the cartilage which is coming out? Just
Yes, sir. So how laterally or lower? How much
yeah, you can
you should go
uh,
till the end of the cartilage? Lower
yeah,
lateral.
till the end of the cartilage. Yes.
Okay, sir.
But what I observe in different cases by doing different surgeons, that it always come in the midpoint of the ala.
Yes, the ala. You just cross the midline of the ala, sir.
Just
Most
cross
of the
the.
time, yeah. Section karo idhar.
So anybody should not go lower than that.
Too laterally, because too laterally it starts bleeding then. And that is really troublesome.
Yes.
The oozing from the lateral part of the ala, because that area is, this part of the area ala is very vascular.
इधर आ जाओ भैया.
So, other than a demonstration, generally after infiltration, you would wait for 5
Yeah,
to 10 minutes?
10 minutes minimum.
10 minutes.
10 minutes minimum. Sections. So can you see this lower border of lower alar cartilage?
Yes, sir. Yes, sir.
So just do some dissection and do the blunt dissection by spreading the scissor. Now there is no any commercial attachment, but these instruments are all made from Medicon.
Yes, sir.
What is the BP now? Because little oozing is more.
BP has just little bit increased.
Dr. Bhati is there, an anesthetist, my classmate, and we are associated since last, I think, more than 40 years. Classmate था और उसके बाद फिर इधर practice में.
So I have delivered this dome on this side.
I think this initial steps is also required
Yeah.
a lot of learning curve.
Yes.
Because जैसे कहते हैं ना कि
Now I go transcolumellary in columnar through the incision.
well begun is half done. It is really critical to give. Initially जब मैं करता था, हमेशा गलती करता था. दिखता बहुत अच्छा है गुबिश के हाथों में सबके, but ultimately these are steps which has to be mastered in cadaver. For PGs I am telling this. Yes.
Sir, what is your experience like in similar incision when you're taking in revision cases?
Yeah, revision you
Is
should
it-
be very, very careful in the revisions,
Yes, sir.
because there is lot of fibrosis.
And the pliability of the skin also
Yeah,
would be less.
is
Sir, how long after trauma would you like to wait before you take up a patient?
6
for
months, 6 months,
6 months.
minimum 6 months.
Yes, sir.
So I have done dissection in front of both the medial crus. Can you see this?
Yes, sir.
So I have dissected the dome on the right side and also the medial crus. ये पकड़ो अभी. Now tell your assistant is holding the Kilner retractor and you are holding the skin with the forceps, so that there is a traction and counter traction and you are dissecting in between. See the difference in the field, the moment BP comes down and the heart rate comes down, the field has improved. So after making dissection on both the sides, we will just take the columnar incision. यहाँ से मत दबाओ.
It is so wet. See, mop करने पर ये dry नहीं होता है. So the incision is taken at the narrowest part of the columella. Usually it should be an inverted V incision, or you can take the stair-step incision.
सर आपके हेडलाइट की ब्राइटनेस भी थोड़ी कम होती है क्या? क्योंकि वो जैसे ही आपका हेडलाइट का एरिया आता है तो थोड़ा सा ग्लेयर करता है, और although it is visible but it will become more better.
सर मैं रिड्यूस करता हूँ उसको थोड़ा.
Okay, thank you sir.
कमी कर जरा.
But see your convenience first, because we are able to see it. We are wanting more to see. That is why we are requesting you.
Sir, medial crus on the left side has little bit cut. I will repair it. I have noticed it.
Yes sir.
It is partially cut. I will take care not to cut it more.
So do you use cautery sometimes in?
No, I don't like actually. I don't like to use the cautery.
Yes,
It is always better to not to use the cautery, because healing and everything.
So the gauge
Sir,
piece.
अभी glare कम है.
हाँ sir, कम है अब. The gauge piece which you are using is
Yes.
plain saline or adrenaline?
Yeah, plain saline.
Plain saline.
Vikas, can we irrigate in between?
Yeah, I'll tell assistant to irrigate. Just I'm elevating the envelope first.
Okay.
ठीक है अभी. So I'm going in a smash plane.
Yes.
No too much of lateral dissection. So the lateral dissection on the towards the lateral wall of nose and the nasal bones to be done. There are certain conditions, in that conditions only. So lateral dissection has to be minimal. You should work in properly sized pocket.
So what are the exactly limits for laterally going?
Your off reach should fit in between, that's it.
Okay.
That is the practical limit. It is not in mm or anything. Your off reach retractor should fit in that area, that's it.
So you elevate the whole
Yeah.
plane
I go up to the radix
and
first.
then come back and again elevate the periosteum separately.
So the septal elevation is done afterwards.
No, so I was asking about the periosteum, like now what you're doing.
Yeah, I find out the periosteum first,
Yes, sir.
and then I elevate it with this side knife and the circular knife.
Yes, sir. Otology.
Yeah. So take the incision with this, find out, and once you are in that plane, then I use this elevator for elevating on the radix.
Yes, sir.
I think somebody has to adjust the V-tomb image. Shivji, Shivaji. Yes. Adjust the V-tomb so that we can see inside. Sir is elevating the periosteum, I think.
Yeah.
Kirti madam, we can see the nasal bone, no?
Yes,
Yeah.
sir. Yes.
Now I have gone up to the radix.
Yes.
What?
So for our PG, sir, what is radix?
Radix is the area wherein the glabella is turns to the nose. So the area wherein the frontal bossing ends
Yes.
and the nose starts is that part is called as radix, and it is formed by the nasal bones. You will find a median nasal suture in that part.
Sir.
Radix is nothing but is starting point of the nose.
So, sir,
Section
right
जरा
now
कम
you are
करो.
above the perichondrium and below the periosteum.
Yes, I am above the perichondrium and below the periosteum.
Right, sir.
Yes, exactly. If you see this, there is a deviation on this side.
Yes, sir. So right now also you use cold saline or only
No, no,
after
no.
osteotomies?
No. Only after osteotomy. This is just
Normal saline.
normal saline only. I am giving the just little bit pressure so that the oozing should stop.
Yes, sir.
No need to use cautery.
Yes, sir.
The moment you give some pressure, it stops.
Sir, I've seen one of the foreigners use cautery, the Colorado needle, to shape the cartilages. But seeing that it is
No-
so frightening,
Yeah,
I don't know what is going to happen post-operatively.
See, in the delicate part, you should respect nature.
Yes, sir.
पकड़ो.
And foreigner has got the very thin skin envelope, then it becomes more risky.
Yes, we have at least
Thick skin
more
envelope.
thick skin.
Indians.
The subcutaneous tissue is also thick. Section छोड़ दो, ये पकड़ो.
Sir, do you always check for the strength of the cartilage before
Yeah,
surgery?
definitely. That is in the pre-operative assessment only.
Yes, sir.
So how you check, sir?
Sir, by pressing the tip recoil.
Tip recoil.
So
Okay.
does that
Yeah.
change your approach or
No,
think like
no,
if it's a
nothing,
very thin
nothing.
small cartilage and you think okay we might have to augment
See,
it?
the thin cartilage or the thick cartilage
Yes, sir.
is racial. It
Yes,
is
sir.
seen in that person, it is familial.
Yes, sir.
So once I do some membranous dissection, I always dissect in the scroll area and I separate it from the upper lateral cartilage. If you see while talking, I have just dissected, and we see this, follow this medial crura, and this
Yes,
is the lateral crura. So medial crura, intermediate crura, and the lateral crura. And I have dissected it from the upper lateral cartilage, and this is the area of the scroll with the thin vestibular skin. So this will, unless I do this, my tip will not come up after reconstruction. The drooping tip which is there, if I want to bring it up with the septal extension graft, unless I do dissection, it will not come up.
Yes, sir. That's a
got
wonderful
my
point,
point?
sir.
Yeah.
Yes, sir.
So few steps are to be done now, keeping in mind the what reconstruction you are planning. ये छोड़ दो अभी.
Yes, sir.
So this side also you do the same steps.
Yeah, same. So follow this medial crus,
Yes.
and you are not cutting any cartilage. You are just cutting the fibrous attachment between the two cartilages. Done it, sir? See, देखिए sir.
Yes.
And this is the skin which you have just lifted. So both these crura are now coming at a higher point, at least 5 mm above the dorsum.
Right, sir.
Okay. So once this is done, now the next step is to find out the anteroseptal angle. So I am applying 2 mosquito forceps as for a retraction.
So when you are elevating,
Yes.
do you try to keep as close to the cartilage and have maximum soft tissue going up in the flap of the
Uh,
nose, or just
some part of the soft tissue I always keep on the cartilage, at least on the lower alar cartilage.
okay,
So I don't make it absolutely bare,
okay, okay, sir.
because the Indians have thin cartilage.
Yes, sir. Yes, sir.
Some या यहाँ पकड़ो ये
Sometimes, like, sir, you have
नहीं
a
नहीं
lot of boggy skin and
Yes.
sebaceous skin.
yes,
So, in those, do you excise some part or you let it be how it is?
if you are planning the grafts, additional grafts, then yes, you need to make that area bare.
Space. Yes, okay.
अभी छोड़ दो, ये पकड़ो.
So what you are cutting, sir, it's a,
Yeah, now I am just finding the anterior septal angle. Just I have found out.
yes,
Anterior septal angle is the point where dorsal septum turns into caudal septum. If you see this point, you can see this.
yes,
So just to reduce the excessive glare,
yes, sir, we are able to see.
yeah. So now I am dissecting, elevating on the convex side, the mucoperichondrium. Okay, and now I am dissecting, just taking incision to dissect the upper lateral cartilage from the caudal septum, sorry, dorsal septum. So can you see, appreciate this?
Yes, yes.
Yes, sir.
Our keystone area is above. That is
Yeah,
the junction
it
of
is
the
above,
bone and the
above,
cartilage.
above, yes.
Yes. You are just separating the upper
Yes.
lateral cartilage with the septum.
Yes. And now this is the proper plane. You can see avascular plane.
Yes. Like we do with the endoscope. You
Yes.
are coming from the above.
Yeah, it is always easier to find out the plane from above, and also it is easier to dissect on the convex side because everything is held tightly.
Right, sir.
Also, there are more chances to get tear on the convex side. So it is better to start dissection with the convex side first. पकड़ो ये.
I think this is true for endoscopic septoplasty also.
Yeah. So the difficult side has to be approached first. That should be the dictum.
Even we can see the deviation.
Yes. So deviation is in the vertical axis,
Yes.
going up to the keystone area or the high, so it is definitely high deviation, as we call it, which is not possible to get it treated transnasally.
Yes,
Ah,
sir.
that
The
is the,
conventional septoplasty, yes.
that is
So-
why the open approach has to be learned,
Yes.
because most of the
Yes.
high deviation cases we do the incomplete work
Yes.
by doing endoscopic septoplasty.
So once I have elevated on this side, now I will go on the opposite side.
Sir, aren't you tempted to use the endoscope for the
Yeah,
posterior part?
you can use the endoscope, but again there becomes more soiling. Then the VTOM is attached. How many?
Yes, sir.
You need one more camera.
Yes, sir.
ये छोड़ दो अभी. You need one more assistant.
So much
Yes.
of time wastage
Yeah.
also.
सचिन करो
We recently bought our second spice also. If you can tell, we can arrange for the next case.
अभी यहाँ पकड़ो, स्किन हुक से यहाँ पकड़ो.
हाँ, तो देख लो. डेलीगेट के लिए बहुत अच्छा हो जाता है. डेलीगेट के लिए it becomes very good. And उसको
So tachycardia can also be troublesome for the rhinoplasty.
Tachycardia is more troublesome than the BP.
Yes, sir.
There is no tachycardia.
I mean, heart rate should be, otherwise Dr. Bhati will say that we are blaming him. He is telling something, I think.
No, all the parameters are very well maintained. You can show on the screen.
Thank you, Dr. Bhati, for your excellent. I think how he is doing with the closed
Caesar.
scissors.
I'm finding my plane with the closed scissor. I'm making this dissection sharp with the scissor. I'm not using any elevator.
I think Medicon has got very good suction elevator.
Yes. So in the area of the nasal wall, I am elevating from below up like this. If you see, so just bear with me. Now I am working in the depth of the nose. It is beyond the capacity of any VTOM, but I am doing just elevation which we do in a routine septoplasty. Same elevation of the anterior tunnel and the inferior tunnel that I have done just with the help of scissor.
We can appreciate.
Yes. So there is nothing different in this elevation. Same elevation, only thing I have done it from the above. There is a concept of septal T, septal Y and the septal I. Now yesterday I have shown the osteotomy, paramedian osteotomy with the burr. Now I will show paramedian osteotomy with the scissor. So
Okay.
this is the double action scissor. This is really good scissor from the Medicon. So just go in the plane and do paramedian, see.
This is great, sir.
This is done. So
For
in a
which-
one go you have done the paramedian, most difficult part of the paramedian you have done.
Yes, and very well controlled.
Yes, very well controlled.
Otherwise, we use sometimes drill, chisel, or sometimes that fancy instrument which is called piezotome.
Piezotome, yes. No, in the next case I may show you the piezotome so that delegates are exposed with all the techniques.
But I think this is more,
Yeah, this is more crisp and fast.
yes, and well controlled.
Yeah.
And your instrument is so stout that it can cut the bone also.
Yes.
So you are extending that.
Yes. Okay.
So from midline he is going laterally, Kirti.
Yeah, I am going little bit laterally so that this root of the nose is very well preserved, and I have done paramedian and I got full exposure on the concave side. So everything is elevated on the left, on the concave side or the right side. Now the convex side I can get some may get some tear in the mycoperichondrium, but that is accepted. At least on this side there is no tear, so I am sure I will not develop any accidental septal perforation, iatrogenic septal perforation. Hold this.
Sir, in this the septum is totally going on to the left side.
On the left side, yes.
So, would you consider doing a extracorporeal?
Modified extracorporeal. Let me expose it first.
Okay, sir.
Then I will decide what technique to apply.
Yes.
Let me first expose the septum first.
Another paramedian osteotomy.
Yeah. This side I will prefer to do with the osteotome. Hammer. Dhire dhire, dhire dhire, delicate. Delicate. Just a bit.
So the Vikas sir has preserved the keystone area, and lateral to the keystone area he is making the paramedian osteotomies.
Okay. ये थोड़ा पकड़ो ऐसा, ये सेक्शन. So my osteotomy on this side is also complete.
Yes, sir.
So complete paramedian osteotomy is very, very essential. Now wash.
Sir, would you consider reducing the height of that hump there and then doing it, or this way only?
Madam, there is no hump. Actually, because of deviation,
Yes, sir.
this portion has gone down of the septum.
Yes, okay, yes, sir.
So
right.
that's why this is not hump, that is pseudo hump.
Yes, sir, I got it.
Okay, see retractor pakdo abhi. Okay, now I have done paramedian osteotomy on both the sides.
Yes.
I have exposed most of the mucosa, complete elevation on the right side, Some elevation on the left side is still remaining. I am just doing it with the suction. The inferior tunnel on this side I have not yet elevated because that is below the deviation. ऊपर से आता है ना ब्लीडिंग, ऊपर से सक्शन करो, ऐसा ऐसा रखो, यहाँ से आता है ब्लीडिंग। यहाँ पकड़ो ऐसा। So now I am elevating in front of the anterior nasal spine, doing dissection in front of the anterior nasal spine, so that I can go below the deviation, inferior tunnel on left side below the deviation. Side elevator कुठे आहे रे? शिवाजी इथं जरा फोकस करता आलं तर इथं हे दिसतंय. When I am elevating in front of the anterior nasal spine on both the sides.
Yes, sir.
So this elevation is very, very important to see the condition of position of anterior nasal spine, whether it is short, over projected, deviated, how it is, because all your reconstruction is going to lie on the anterior nasal spine and the maxillary crest.
Yes, sir.
So dissection of anterior nasal spine on both the sides. Can you see it well?
Yes, sir.
Can you see it well now?
Yes, better, sir.
Yeah. So this is caudal septum, this is dorsal septum, and this is anterior nasal spine.
Yes, sir. Right, sir.
Okay.
Yes.
So I dissected on both the sides of anterior nasal spine very well. Now we will just release the septum from maxillary crest, whole septum from maxillary crest, and now I will assess this vertical fold of the deviation, and then I will take the decision whether to go for extracorporeal or modified extracorporeal.
Yes, sir.
In the extracorporeal, we did yesterday extracorporeal because the whole septum was deviated and fractured in the keystone area only. So it was not possible to reconstruct the keystone area without any deviation if I kept that in situ. So I am taking the septum out, hammer, from maxillary crest.
You take the septum out, you hit over the maxillary crest.
Yes. जोरात. So my intention is always harvest a big piece of the cartilage, not in the pieces. The cartilage has to be taken as a single unit. Deviated cartilage has to be taken as a single unit. Then you can reconstruct the way you want it. If it comes in a piecemeal, then it becomes difficult to reconstruct.
So, do you generally take consent for harvesting conchal cartilage as well, always as a
We do take.
standby?
We do take.
Because sometimes when you open the cartilage, you realize that the quality is very bad. And
Yes. It is always better to tell them that
yes, sir.
even not even the conchal, the costal cartilage also I tell. In the yesterday's case,
Yes, sir.
it was surprise for us that the quality of cartilage was so bad.
Yes, sir.
So we took the consent for the costal cartilage.
Okay, sir.
I think we call patient attendant in the midst of operation, then counsel him for 20 minutes, Then they agree they have different fancy questions whether it will affect our liver or he is a badminton player, if there is any problem in the chest. But ultimately with the persuasion of Dr. Vikas Kulkarni, they agreed. And the graft was taken, to my surprise, it was only, I think, 10 minutes.
Yeah.
Sir has removed the costal cartilage. Very effective way of doing it.
So which conchal cartilage or costal cartilage do
See,
you prefer?
7 and 8 are the most preferred.
Yes, sir.
But yesterday we needed the cartilage only for dorsal augmentation, a straight solid piece. So I took ninth. 7 and 8 are most versatile.
Yes, sir.
You get length as well as volume, as well as the solid rib also you get.
Yes, sir.
8th is most ideal. But if you need lot of reconstruction, then you may need 7 and 8. So if you see this, I have completely separated the cartilage from the maxillary crest and it is loose.
So you've also separated it from the vomer and ethmoid behind?
Yes, yes.
Okay.
It is attached to perpendicular plate of ethmoid.
Okay.
I have not separated it from the ethmoid. इसका जरा ब्लॉक निकालो छोड़ो 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 नहीं ब्लॉक झाले जरा नहीं हे
So do you use gentamicin or something in the
yeah in
irrigation?
the saline which I am using for irrigation
Yes, sir.
in the 2 bowls the 2 vials of gentamicin are already instilled.
Okay, sir.
Kyun? Why?
Pardon?
Why you use gentamicin?
No, it is a what you are the irrigating fluid is containing antibiotic. That's it.
Okay.
So if there is accidental tear on one side, as such, that doesn't lead to a
No,
septal
no.
perforation.
But that's why the
But what infections and all,
no, madam, nothing happens.
nothing happens.
Yeah. See, when you are using the graft like the costal cartilage graft,
Yes, sir.
free grafts we are using, then it is better to not to have any tear.
Yes, sir.
But also not having tear is there are big chances of forming the septal hematoma.
Okay.
So you have to weigh between its benefits and the risks.
So suppose there are accidental tears bilateral, then you repair it.
Yeah,
then
yeah,
and
you
there?
have to. You have to repair intranasally. That is the best chance
Yes, sir.
to prevent the septal perforation. So if you see this, now I'll be preserving at least 1 centimeters of the dorsal septum. See, the deviation is coming here, and I'm getting really good piece of the cartilage, which is the straight.
Yes, sir.
Can you see this?
Yes, sir.
Yes.
So I will take out the remaining piece of the cartilage, but the dorsal 1 centimeter of the septum will preserve it. I will mark on the concave side. No, I will mark on convex side because that will be seen better. Instead of marking on this side, I will mark on this side because that will be seen better through the VTOM. So for marking, I always use toothpick.
Okay.
So toothpick is, I find it better than anything.
And using methylene blue?
Yeah, no, it is a marking ink made by Royal Chemist, Mumbai.
Okay.
It is a combination of lot of things. So I'll be,
But your toothpick is like a pencil,
yeah.
specially made for you, or it is sterilized
Now-
one?
Can you see this?
Yes.
Marking. So I made it here vertical and I have gone horizontal. Now I'll tell you the science behind the marking. See, if you see the bridge, any bridge has an arc.
Your hand is, we are not seeing. Yes. Zoom out करो बेटा
No,
थोड़ा
no,
तो दिखेगा.
ये रखा, ये दिखाओ.
ये सर की
Bridge has an arc.
नहीं सर दिखा नहीं रहा वो. एक्सटर्नल कैमरा.
External camera.
एक्सटर्नल कैमरा दिखाओ बेटा सर का ये. हाँ सर आपका वो हेडलाइट ऊपर कर लीजिए. हाँ आप दिख रहा है सही.
So bridge has an arc. So this is the part of the bridge which is attached to the perpendicular plate of ethmoid. So when you are marking this should be small and this should go below. So this attachment of the septum, it should be the maximum.
Yes, sir.
2.2 to 2.5 centimeter to the perpendicular plate of ethmoid. This can be smaller. This can be few mm. This can be 5 mm also.
Towards
You
the
got my
dorsum.
point? Towards the dorsum.
Yes.
So the marking should be such. So this is your dorsal border. This is your perpendicular plate of ethmoid. This is the incision which you have, the marking which you have made on the cartilage, and it should go below. It should not go straight backwards.
Right.
Yes,
Then it
sir.
becomes weak. So it should go below.
Very nice.
So then this attachment is very firm when you are planning to modified extracorporeal.
Yes, sir.
You got the point?
Yes,
sir.
sir.
Yes.
Okay. So I'll show you in surgical scenario now this concept which I have told you. So here there is a deviation. So we are taking just, I have taken this few mm incision, say 5 mm incision on this side, and now with the curved scissor I will be cutting the cartilage so that my attachment to the perpendicular plate of ethmoid is more.
So your hand is obscuring, sir. In between you can show us.
Yes, I will show you, sir.
Yes. So see how he goes downwards, not straight behind.
So this attachment to the perpendicular part of the ethmoid is preserved maximum, and take this out.
So you've taken with the wormer.
Yeah, I have taken it
Yes,
with
sir.
the wormer.
Yes, sir.
I have taken it with the wormer. So the most of the deviated portion has come in spite of coming out in the body, out of the body, still it is not ready to leave its curvature. So you have to make it straight. You got my point?
Yes.
Yes.
So this is modified extracorporeal. We have preserved say around 1 centimeter of the septum here at the keystone area. So this will straighten it with the spreader grafts. Okay.
Yes.
And we have very strong and stable support. Residual septum which is in the posterior half. I will just shave a little bit more so that I should not have, because the remnant cartilage is too big. Because if at all I want to do the radix augmentation with the free dice cartilage, I should not be falling short of some cartilage.
Sir, after once you've removed the partial septum,
Yes.
reconstructing and deciding to what height
Yes.
to
Now,
get it back
good
is
question. Good question. Really good question. I'll tell you. I'll tell you what makes me to decide all those things.
because, sir, post-operatively I've seen sometimes you feel,
Yeah.
oh, the rotation,
So this is the natural height of the septum.
yes, sir.
The caudal border you mean to say, no?
Yes, sir, because the rotation, the whole.
No, I'll tell you, sir.
Yes,
Madam, I'll tell you, madam. So this is 2 centimeters.
yes, sir.
Now, if you see the tip is drooping, there is acute nasolabial angle.
Yes, sir.
So if this is 2 centimeters,
Yes, sir. Right.
if this is 2 centimeters,
Yes.
you will definitely need 2.5 centimeters
Okay, okay, right, sir.
because it is drooping.
Yes, sir.
So the new septal angle, so everything is related with the septal angle.
Yes, sir.
So you are going to create a new septal angle which is at new height.
Okay.
That will take care of your drooping tip. See, the support of the tip is from the septum, anterseptum and the septal angle.
Yes, sir.
So you reconstruct this, and to that you can add the septal extension graft at a new height
Okay, sir.
and the new projection.
So before taking out also for beginners, if we measure and then keep
Yes, it is always
add
better.
another.
See, the drooping tip tells you that the septal angle is placed at low height.
Yes, sir. Got it, sir.
So you have to bring it up.
Yes, sir.
I think very important point.
Yeah, and that is the best support for the nasal tip. Now another important step which I do is making groove in the maxillary crest and making hole in the maxillary spine, intranasal spine. So for that I use burr, Linderman burr and Shivaji.
To make the septal, I mean, like column, this angle 90 degree, they will use the septal extension graft.
शिवाजी मैडम वो ये दे दो फॉर्मेलिन चेम्बर में आपके ये रखा होगा उसने हैंड पीस और बर रखा होगी वो दे दो एंड आई नीड अ मोटर नाही गेला ना नाही गेला ना तुम्ही आता काढला बारीक पीस
So we would also like to know how you plan your osteotomies.
In this case I think only paramedian is enough.
Yes, sir.
No osteotomies because the base bone width is normal.
Okay, sir.
It is not wide. Also the height is also normal. There is I don't want any augmentation
Yes, sir.
in the bony dorsum. Section बढ़ाओ जरा. Mind I want a motor. अरे ये ब्लॉक आहे रे फ्लॅश करून ब्लॉक काढ ना याचा शिवाजी मोटर घे मोटर हँडपीस बर
So do you get a pre-operative CT done in patients
yes
with
in each and every
TNS?
patient. Now the
All
most
cases.
important thing is CT will tell about the additional pathology number
Yes,
one.
sir. So do you operate simultaneously if there are?
Depends, but I do. If the CRS is there, then no.
Okay.
Means no face and rhinoplasty at a time.
Yes, sir.
But turbinate reduction, conca, yes.
Okay, sir.
In yesterday case also, he did terminoplasty of both the sides.
Sir, do you operate only for functional rhinoplasties or
No,
do
no, I
you
do
do
cosmetic
cosmetic?
also.
als-
Yes. See, it is a learning curve, madam.
Yes, sir.
So, say after 300, 400 rhinoplasties, you start gaining the confidence. And you really you come to know the actually the everything is about assessment.
Yes, sir.
See, the experience makes your assessment. There are a lot of steps which you decide on table.
Yes.
So it is always better once you become experienced, then your decision making and everything improves.
Yes, sir.
झालं मोटर रेडी मोटर रेडी आहे ना 15,000 ला कर Now I make hole in the spine with the help of needle and the Linderman burr with the hack adapter.
Kindly show that assembly to us.
I'll show. This is the straight handpiece by Benair. This is the hack adapter, and to that I have attached the needle. See. So this converts needle into burr. You got my point?
Yes.
Yes, sir.
Yes. So attach it to the handpiece.
So that is also Medicon.
Yeah, this is also Medicon. Now lot of others are making, but the quality, then it should not wobble. Everything depends upon the quality. So I am just coming from the base of the ala. And I get going exact perpendicular to the internasal spine. ये पकड़ो जरा.
I think very nice technique because we have seen people struggling
Can you
into the
see?
nose. He's coming from the outside and we can clearly see how he is making the hole.
Can you see it, madam?
Yes, sir. Wonderful, sir.
The needle which has gone through and through the internasal spine.
This I'm also seeing for the first time.
Yeah.
Otherwise, many people use piezotome, I think, for
Yeah,
this.
piezotome is
With-
really good in this scenario. In the piezotome, you can no need to go through the cheek or the lip.
Yes, sir.
Burr. But piezotome, very few people are having piezotome.
Yes, sir. We are always struggling with the
Yeah,
diamond burr only.
Yeah.
But piezotome is now available very cheaply.
Yeah, it is very cheap now. 2.5 lakhs, I think.
I bought it 1.5 with lot of bargain with my dental colleagues' help.
Woodpecker.
Woodpecker. Yes.
Yeah, I have also gone for the woodpecker, but he charged me 2.5.
You should have contacted me.
So I am making notch in the internasal spine in the midline exactly with the Linderman burr.
Very nice.
So that your assembly should fit nicely. Anterseptum should fit nicely in the midline. So now comes the reconstruction. Osteotomy we are not doing. What I need is 2.5 centimeter of the caudal septum minimum, then the two spreader grafts or the beam grafts for holding the anterior septum, So I am just have taken out the bone from this assembly. So I will plan where I am getting 2.5 centimeters minimum septum. .5 centimeter in height. You can see this.
Yes,
Yes,
yes.
sir.
Okay, and 1 centimeter in width at least. Ink.
External camera, please show what he is doing.
So 1 centimeter width, you're talking about the dorsum.
No, width
With-
of the vertical assembly.
What? Oh.
You got it?
Yes, sir.
So this is 2.5 centimeter by 1.2 centimeter. You got it?
Yes, sir. Yes.
Okay. So we'll harvest so now this is my caudal septum,
Yes, sir.
and remaining I will use for the beam grafts, the septal extension graft, remaining whatever required I will design from this.
So you for spreader graft dimensions you keep
Spreader graft minimum 2 centimeters.
yes, sir.
So this is my one beam graft. Now in the modified extracorporeal septoplasty, it is called as beam graft. So
Okay,
this is my one, this is my another.
okay, sir.
So it will be fitted like a spreader graft only, but it is called beam graft in modified
Yes.
extracorporeal.
So you take it up along the ethmoid also little bit.
No, 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 no. Bone is not at all there.
No, no.
It is
I mean
pure cartilage.
the graft that you're putting
Yeah.
as a beam, you put it from the key area only,
Yeah,
or
from
little
the
bit
keystone area,
it goes
along
little
with the
under also.
along with the remnant septum
Yes,
to
sir.
the new vertical assembly.
Okay, okay.
So these two beams will connect the vertical beam,
Okay, sir.
which is fitting on the antennal spine. That's why it is called as beam graft.
Yes, sir.
So first, now as we are not doing any osteotomy, so the deviation is on the right side, on the left side. So out of the two, the thicker graft will be on concave side, that is on the right side,
Right.
and the thin graft will be on the left side. So just to camouflage and to make it mimic like a straight dorsum.
Yes, sir. So
See retract.
the left side nasal bone was a little longer. You said?
No, 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 not in this case.
Okay, sir.
In another, the second case.
Okay, okay,
The
sir.
second case has facial asymmetry.
Okay, okay, sir.
That patient is having definitely longer nasal bone.
Okay.
needle.
I think delegates feel free to ask any questions. You know, ask to Kirti madam or discuss. It's a closed room discussion. Any doubt you can ask immediately. So a stronger one on the left side, right
Yeah.
side, sorry,
Needle.
thinner one.
Take a longer and shorter needle.
ये तो राइट साइड में रख रहा है ना पेशेंट के.
I am putting thick graft, relatively thick graft on the right side, which is the concave side.
Yes.
So applying the needles is very tricky. Applied the needles in just little bit cranial, the upwards orientation. I want more right here. So they are little bit in upward orientation. 50 PDS.
So how much it goes beyond the keystone area?
Beyond the keystone area, they are almost 1 centimeter.
1 centimeter.
Yeah. See.
Okay. Yes. Which suture you are using?
This is 50 PDS.
50 PDS.
And I am suturing beam grafts separately, one on the right side and one on the left side. They will not be taken in one go. Wash. बस बस बस. Minimum 2 sutures for stabilization.
So you'll need some camouflage also for the dorsum for those osteotomies. Like you said, you might use diced cartilage.
For the radix, I may use the radix, the free dice cartilage.
So if you don't use, does it matter, or it's okay? But it
No, it gives a very smooth appearance of the dorsum.
okay, sir.
थोड़ा नजदीक काटो. Okay, nice. So my this beam graft is now stable. No, I have to make it stable here. Section.
तो सर बीम ग्राफ्ट को आपको अपर लेटरल से जोड़ने की जरूरत नहीं है.
बीम ग्राफ्ट को मैडम क्या क्या सर बोले?
You need not to suture with upper lateral cartilage.
नो नो बीम ग्राफ्ट अभी सर नहीं अपर लैटरल कार्टिलेज को फिक्स करेंगे. विल फिक्स इट एट द एंड.
Okay.
वर्टिकल असेंबली को सुचर करने के बाद.
Okay, sir.
कट. And now it is stable. We will put a thinner beam graft on this side.
long needle thi.
So this side you have taken upper lateral also in your.
Yeah, I will not suture it with the upper lateral. I will suture it with this septum only.
Okay, for stabilization you
Yeah,
have taken.
just for the sake of stabilization, I have to, because it is retractable. See.
Okay, right. You can put your suture
Yeah,
there.
yeah. Now both the beam grafts are placed in a nice orientation. Wash. यहाँ दे दो ना wash. बस बस बस. I have taken one horizontal and now I will take one vertical. Yeah, now both the beam grafts are stable. Okay, and it has become straight also. The dorsum has become straight also. छोड़ो 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 अभी जरूरत नहीं. Okay, now once you have fitted both the beam grafts, will fit the vertical assembly. You got my point? See how
Yes,
nicely
sir.
it has come in between. And this is your new septal angle. Okay?
Yes, yes, sir.
Long needle. अगर मैं ये 2.5 से कम लेता तो ये बहुत शॉर्ट पड़ जाता. See, now it is exactly sitting on the nasal spine. See, in the desired orientation which you want. यहाँ दिख रहा है मैडम?
Yes, sir.
Yeah.
Sir, वो जो बीच में space रह रहा है, that is okay?
This space, no, we'll fill that.
Okay, sir.
We have lot of small piece of cartilage.
Yes, sir.
We'll fill that space.
Yes, sir.
थोड़ा सा सेप्टल एक्सटेंशन तो बीम ग्राफ्ट के आगे आ ही रहा है.
हाँ.
New tip, yes. And that is, again, you need some septal extension a little bit.
Maybe. That
Maybe.
I may need, because I want it in a caudal direction also, in this direction as well as in vertical.
Right.
क्योंकि उसका टिप सर बहुत ऊपर लेना है, that is a drooping tip. So instead of sutures, solid grafts are much better for the tip position. हमने सब पढ़ा था suture के बारे में, suspension sutures के बारे में,
Yes, sir.
but support from below with the solid graft is much superior to the suspension graft, suspension sutures.
Yes, sir.
The hole is already there.
Yeah.
We are finding that hole. Suction कर रहे हैं.
So I apply bulldog clamp as a hold for that suture at its end.
Right, sir.
These steps are very crucial deciding the stability of whole assembly. So take proper time for this, don't make any hurry while passing these sutures. All these are structural support grafts, so they are going to decide all your results.
So minimum 4 passes
Okay.
for the intranasal spine. So 3 are over. I will be taking one more. I think 2 are over.
3 are over.
3 are over through the hole. Now this is the third one through the cartilage.
So any pattern you follow?
Depending upon the maximum stability I get. The first one, then the second one in the behind, third one in the front, and fourth one depending upon where I am getting maximum stability or the stretch where it is required. According to that I will place it.
Sir, if the anterior nasal spine itself is crooked, so then you place
So
it.
madam, you can drill it.
Okay.
Drill it on the side where it is crooked.
Yes, sir.
Make a hole, make a notch.
Okay, sir.
But that is very, very precious area.
Yes, sir. Because
The whole, the stability of the whole assembly is lying on that part,
yes,
one
sir.
part.
So the stiffness of the nasal tip goes away after 6 months.
Yeah, it goes away, madam.
Yes,
Even though you do the, even if you do the tongue in groove,
Yes, sir.
when you do tongue in groove, the stiffness is little bit more.
Okay.
For the tongue in groove, the patient mainly complain they cannot make the tip up.
Okay, okay.
हम किसी को चिढ़ाते हैं ना, तब जैसा
हाँ.
टिप हम ऊपर करते हैं
Yes, sir.
उंगली से, वैसा हम नहीं कर सकते with
Yes.
the tongue in groove. But overall the stiffness is not bothersome,
Yes, sir.
not at all. It goes, it becomes smooth and natural.
Okay, sir.
Only thing, the upward tip rotation you cannot do, excessive.
Yes, sir.
जैसा हम naturally कर सकते हैं वैसा नहीं कर सकते. That is the only limitation. So I have taken this with the ethylon because it is a structural graft. I don't want it to get absorbed so early.
Yes, sir.
It should remain permanent.
So this is 30?
This is 40 ethylon.
40.
And 5 knots.
Yes, sir. So even in PDS you were putting more number of knots.
PDS minimum 3.
Yes, sir.
It is better to put one more knot
Yes, sir.
than slipping the knot. Okay. Now this assembly is strong and stable. Now this
Yes.
upward assembly will suture it with the PDS. PDS किधर गया?
So you keep all the knots on the left side?
No, now I want the pull
Yes, sir.
on this side
Okay.
to bring it in the midline. So wherever I want, the knot is on opposite side of the pull. Loop is on the side where I want the want to bring it in the midline.
Yes, sir.
Cut. I don't use that scissor.
So your centering is what? You're taking the glabella and the philtrum?
Yeah, glabella and the philtrum. And the nasal spine, to be precise.
Yes. Because sir, generally we'll be standing on the right side, so unknowingly sometimes there is a pull towards the right
No, madam,
side.
it doesn't happen so much.
Yes, sir.
Even though you are standing on one side,
Yes,
if
sir.
you position it in the correct anatomical place,
Yes, sir.
and securing it correctly is most important. Wash. So I have taken 3 sutures for fixation of beam grafts to the anterior septum.
Yes, sir.
Now the gap which is in between, will fill something and suture it. Cut. See, now the tip has started coming up, the dorsum is becoming straight. Now this for the tip support, here we will apply the septal extension graft. No osteotomy, definitely, because he is a tall guy, male. I don't want his nose to look like a female. So this base bone width is absolutely normal. So definitely no base reduction, base bone width reduction in this patient.
Yes.
Yes,
Also
sir.
it is not demanding because it is straight also.
Yes, sir.
Now we have one better piece of cartilage left,
Yes.
Yes.
which we'll use for the septal extension graft. And if something usable remains, then
We
we'll do
dice.
the radix. Yeah.
So have you used other materials for dorsum augmentation?
Which other materials?
So those silicon blocks,
No, no,
log
no, no, no,
blocks you
no,
get.
no, never. Never.
Yes, sir.
See, most of the people, those who are following Gubish,
Yes,
he
sir.
says it is a malpractice.
Yes, sir.
That is his concepts are very clear. So instead of it is better to use. See, the problem is there is an inherent fracture. So I cannot take in this direction. I have to take it in this direction. So this much I will use for a septal extension graft.
After putting the septal extension graft,
Yes,
I mean, how much angle you
90 degree.
90 degree
Yeah,
ideally?
90 degree, ideal angle.
So any changes with male and female?
No, male, for us 90 degree is more preferred, in female 95, little bit obtuse. But our females don't like 105.
Yes, so wo,
Absolutely they hate.
the Western and
Yeah,
the
yeah, yeah,
British.
yeah, yeah. Yes. पकड़ो ये.
I think this septal extension graft is a very versatile graft.
Yes.
It game changer.
Yeah, and it has, uh, it is much better to columella strut. Much superior to columella strut because it is more stable. It is sutured with the central assembly.
Yes. And you have made the central assembly very strong.
Yeah.
I think shield graft and other these kind of graft is not required in Indian nose.
No, not required.
Not required because you have got very thick envelope.
So this length, height you said 0.5 add karna hai. For this
No, no, for what?
longitudinal
For
length?
no, you are asking for this graft which I am applying now
Yes,
in
sir.
relation.
Yes,
No, no, I can, madam, trim it.
Okay.
I can readjust it. I can trim it.
So you make it longer, then
Yeah,
you
yeah, I
put
make it
the
longer,
skin
yes.
back and see how much you want.
Yeah, 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 yeah.
Okay, sir.
See, it is always better to put a long graft than the short graft at
Yes,
this
sir.
place.
So you use the cartilage very, very judiciously.
Very, because see, Indian nose has septum has very less cartilage, madam.
Yes, sir. Generally, I've seen people use it in a L-shaped manner. So
Yeah, the
that
single
is
assembly also you can make.
easier to do, but then उतना cartilage मिलता नहीं है हमेशा.
नहीं मिलता है.
Yes.
Because there are inherent fractures inside, so you don't get, you can make it a straight stable assembly
Yes, sir.
with these 3 pieces.
Yes, sir.
मोशन पास किया क्या पेशेंट ने? हाँ हाँ आई थिंक सो. Don't, no. Very. So minimum 5 sutures for the stability of septal extension grafts. So I have taken 2 now. 3 suture के बाद आप needle निकाल सकते हो for remaining 2 sutures.
Sir.
Wash. बस. शिवाजी PDS. It is getting stable.
So you keep your rhinoplasty patients admitted for how long?
2 days.
2 days. And give them IV antibiotics for 2 days and oral
Yeah.
for 5 days.
Remaining 5 days. Yes,
5.
it is better.
Yes, sir. And you keep the cast on for how long, sir?
7 days.
7 days.
Yeah. Keeping it 10th day, I don't find any advantage.
Yes, sir.
So by the end of 7th day, everything is stable.
So many people tend to develop a lot of acne and problems.
Yeah, skin problems
So-
are there.
Yes, sir. So
We
you use that other
no
those
thermoplastic
ready-made-
no. Don't use thermoplastic. Plaster of Paris only.
So there's a question about nasal packs. What do you use?
Merosil always. Better safe than sorry. And along with the silicone splint.
Silicone splint, right, sir.
So I first apply the silicone splint and then I place the Merosil, which is kept for 48 hours. No
So-
compromise on that.
The airway wala splint?
No,
No, without airway.
without airway, complete block.
Okay.
Yesterday, sir, shown his splint. He is using 1 mm
Silicone
A4
splint.
size splint, commercially available, cheap and very good. He will apply, you will see.
Yes, sir.
So this is the fifth suture which I am
Sir,
taking now.
sir, if we do not have spare
Cartilage.
septal pieces, can we use silicone
No.
strips?
No, 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 no. See, it doesn't integrate basically. It doesn't get integrate with the tissue. It always forms a biofilm. The silicone is protected by the body is kept away from by the body by the biofilm. So biofilm is always there when you use the silicone.
Okay, sir.
The other material like Medpore may get integrated with the body, but not the silicone.
What about the refashioned conchal cartilage if you have less of septal cartilage or the fractured septal cartilage?
Yes, definitely you can use it, but instead of concha, I am more comfortable with the costal cartilage.
Which one?
Costal cartilage.
Coastal.
I am more confident and comfortable in taking costal cartilage. Only problem of the costal cartilage is core calcification.
Yes, sir.
But with the use of this piezo, now even though there is a core calcification, you can make good strips of the even the core calcified costal cartilage.
So what about warping and all in the costal cartilage? How do you deal with
Doesn't
that?
happen, madam. If the warping is the
No, you're
is the
using
property of costal cartilage, so you have to master the technique
yes, sir. So you
of
use the whole
shaping the rib. Yes, no, I use rib
full
in all the
complete
forms.
or in slices?
No, I use the rib in all the forms.
Yes, sir. Okay.
So now I am making this complete assembly of 5 pieces, 2 spreaders, septum, and 2 beam grafts.
Yes, sir.
So with the costal cartilage, do you feel there is more of stiffening of the nose, stiffening of that part?
Yeah, it does
Instead-
happens,
Uh,
but after the 1 year, that is not the case. After one, it takes a little bit longer time.
सर वो बताता है कि ना टच करने में क्या बात सर जब दिखने की बात होती है इसमें तो फीलिंग का तो बात होती है
कोण येणार नाही.
So you'll tell us something about the costal cartilage, how
Yeah.
we prevent the warping.
Yes. So yesterday when I harvested the costal cartilage,
Yes, sir.
I showed them how to make it friendly. See, the costal cartilage has inherent warping or the curvature.
Yes, sir.
So you have to give partial cuts
Okay.
on its concave side, releasing cuts.
Yes, sir.
So the elasticity should get released.
Sir. So have you had any experience on resorption of these augmentation grafts?
If there is an infection, then yes, they do get resolved. But if no infection, then nothing happens.
the antibiotics for the patient?
Minimum 10 days. So 7-day plaster removal and then another, say 12 days, another 5 days. So all these are free grafts. So better to have safe.
Which antibiotic do you prefer?
Yeah, coamoxiclav. Coamoxiclav along with levofloxacin.
So what about saline drops or douching? Do
Yes,
you use?
definitely in a nasoclear HD or sol spray is given for 1 month almost.
Okay, sir. And on the external suture line, you put any ointments?
No,
No.
but I recommend to use the saline nasal spray.
Okay, sir.
Cut. Okay, now the dorsum and everything is built nicely, strong, stable and straight. Now what remains is the tip work. Okay, wash. So now we will be giving domal CC retractor. See, this froth should not form. So I will be putting domal creation suture.
Yes, sir.
So pass medially through the intermediate crura, then come out cranial to medial, and then again pass.
Sir, do you ever use bone pieces from iliac crest in rhinoplasty?
No, 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 no. See, any bone is meant to resorb. Bone is not the ideal material for rhinoplasty, but cartilage, yes. Cartilage is the best material. Septal material is the platinum. Costal cartilage is a gold, and conchal cartilage is silver. So septal cartilage is always most precious. So this domal creation suture gives really good dome and it forms a good tip diamond.
So there's a question, what is the sequence like? How do you?
For this,
Yes, sir.
this suture I told, no?
Sir, how do you maintain the symmetry on both sides? It is.
Yeah, first of all, while maintaining the symmetry, you can use needle,
Yes,
but once you are used to it, then it is visible.
yes, sir.
Is there an excess projection that you will trim it?
It's not excess, it
Achha.
is optimum that I have judged it.
Yes, very nice.
So fixing this, the height of the domes with reference to the cartilage is quite challenging, I think,
Yes,
because that will change all the rotation of the
all
tip.
the dynamics will change.
Yes, sir.
There is a little bit of tip bulbosity that I will take care of. Now first of all, while passing the needle, I always take the spanning suture. So that will give stability to my cranial part of the cartilage.
So you will put another caudal strut also?
No, there is no space, madam, now.
Okay.
I will make tongue in groove.
Okay.
See, the cartilage has come in between the medial crura.
Yes, sir.
The septal extension graft has already come between the between the two medial crusts.
Yes, sir.
Wash. See, here you will see it has already come in between, no?
Yes, sir.
So there is no space.
All calculated.
So, have you judged that in reference to the lateral alar base, how much of columella projection you need?
See, the moment you do the nice projection,
Yes, sir.
the LR base reduction happens.
Yes, sir.
So the flaring goes automatically because the tip is coming up.
Yes, sir.
You are supporting the tip from below.
Yes, sir. That's a good point, sir.
Yeah.
How often do you actually need to do a alar base reduction?
Quite often.
Okay.
Quite often in Indian noses.
Yes, sir.
Especially from the southern India.
Yes, sir.
That technique, even I do only ala base reduction in some cases.
Okay, sir.
The females which were unhappy,
Sir.
and if you do only ala base reduction, they get, that is done in the local anesthesia,
Yes, sir.
OPD procedure, quite effective. Only thing is, it is not reversible.
Yes, sir. So, could you show us once you're free the marking of how do you, because getting the ala base right is a very difficult proposition, because the curvature, if you don't suture it nicely, it looks like a pyramid type of a
Yes.
nose.
Wash.
Very nice.
Then now you can see the pyriform aperture.
Yes, sir.
The flaring and everything has gone. Even the columnar retraction has also gone.
Yes, sir.
Flush.
Even the
Fresh
shape of
hege.
the nostrils have come out beautifully.
Yeah. Fresh guazgi. शिवाजी डाइसिंग करायला लाग. Now there is a little bit of cartilage is remaining. I have requested my assistant to dice it.
So how do you put the cast? Can you just tell for the new?
No, cast I will be putting. I will be showing how
Yeah.
everything, how to put the cast. Now there is little bit bulbosity. I told you that I will shave off. You can see here there is it is a bulbous. Laterally you can make it out. Yes, there. See retractor there.
On the left side, sir.
No, on both the sides it is there. So I will just do cephalic trimming and it will take care.
So any drawbacks of this trimming sometimes?
Yeah, you should not do excessive.
Yes, sir.
You should not do excessive trimming. It should not weaken the
So some people cut it and suture it inside that only.
Yeah, yeah,
Does
yeah.
that?
when there is a concavity,
Okay,
then to strengthen that you can do that.
sir.
So just final finishing touches I am doing to this assembly. There should not be any sharp point which is projecting outside, which is palpable. Now my assistant is definitely having really good amount of cartilage or free dice. You can see it. So that's why we have used it very, very judiciously.
Yes, sir.
See, at least we'll get 0.75 ml in a tuberculin syringe, and that is really significant volume.
Yes, sir. So you don't wrap it in any perichondrium or anything?
Which perichondrium?
I mean, from a fascia.
Bag, taking a
Your
bag. So.
voice is breaking.
So do you wrap it in some fascia?
No, 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 no. It is not the dice cartilage in fascia. It is a free dice cartilage.
Just free diced. Okay,
Yeah.
right.
For dice cartilage in fascia, you will need some fascia, either temporalis or rectus or fascia lata.
Yes, sir.
Actually, that much augmentation is not required.
Yes, sir.
So this free dice will be placed on the radix as a free dice cartilage.
Yes, sir. So how much the height of the dorsum and the height of the lower lateral alar cartilage domes?
Yeah, it should be 5 mm above.
5 mm above.
The dome should be minimum 5 mm above the dorsum. See, this is the dorsum, this is the dome.
Yes, sir.
Then you get the good projection and
Little
the
supratip
break point also.
Right, sir.
See, it is a very strong, stiff and stable.
Yes, sir.
So now I will put the silicone splints. These two are silicone splints. The sir which sir was telling about.
So
These are made through the sheet of silicon, which is 1 mm in thick, and it is food grade silicon.
okay, sir.
There is a silicon which comes as a food grade and the industrial grade.
Sir. So this is
So
readily
these are,
available?
yeah, these are readily available and these are reusable, autoclavable.
Okay, sir. So you shape it and
Yeah,
design
you,
it according to your
you
need.
make a shape and you give a cut so that it overlaps and you can put it nicely inside. The best part is it gives uniform pressure.
Yes, sir.
The biofilm and the formation is not there. Then also the nasal patency, it maintains very well. No synechy.
So when do you remove this?
7th day.
7th day, okay.
If sometimes clear air will be, it will also help.
You take the suture like a transfixation suture and suture it. Stabilize it to the septum.
So you don't take separate quilting sutures on the septum?
No, this is the one.
One
This is the
suture
one only.
Okay.
See, because of the quilting suture, there are chances, multiple quilting sutures,
Sir.
there are chances of septal perforation.
Yes, sir, because the needle sometimes pulling and pushing only itself causes a lot of
Yeah.
trauma.
And the thing is, see, while elevating, there is a vessel which is just behind the antennasal spine, which is going in the incisive canal.
Yes, sir.
There is a definite vessel which is going to incisive canal on both the sides.
Yes, sir.
That vessel is giving supply to this anterior cartilage and mucosa, everything.
Yes, sir.
Now, usually what happens, during the elevation and everything, that vessel is usually traumatized when you are doing open approach septoplasty and excessive elevation.
Yes, sir.
So that active supply of that part is lost. Whatever is there is the indirect supply.
Yes, sir.
So any mucosal pressure of the suture
Yes, sir.
will lead to necrosis.
Okay, okay, sir.
So that's why I don't take quilting suture, only one suture just to fix the silicone, that is to be removed on 7th day.
Right, sir.
So you can take the camera laterally. ये camera थोड़ा ये side लीजिए. So I always put the free dice with the open skin flap, because I have to put it here, right here.
Yes, sir.
So I have not yet sutured. I will put the free dice cartilage, and just by putting the free dice cartilage, you will come to know how it is a game changer.
Yes, sir.
So I'll show you the final result before suturing. So now only 2 steps are remaining: the putting the free dice cartilage and suturing.
So
Now can
any
you-
experience of using fillers later? Like
So both the pyriform apertures are equal and symmetrical, and they are elliptical.
yes, sir.
Then the tip is strong and stable. The dorsum is straight. The tip is above the dorsum. There is a supratip break point.
Yes, sir.
You can show from laterally. यहाँ से दिखाइए थोड़ा. ऐसा आप ऐसा झुक जाइए. थोड़ा zoom out कीजिए. Zoom out. हाँ. So can you see the difference?
Sir, do you peg the nostrils with the gel foam?
Now see the nasolabial angle. No gel foam. See
Yes,
the
sir.
nasolabial
It's
angle.
very
You
nice
see it was
angle.
acute. Now it has become obtuse. Even the columnar retraction has gone.
Yes,
Now
sir.
he is getting a straight nose. There is no excessive supratip break also like a female. So lateral view will tell you everything. Now what I am going to do is I am going to just fill this area, and that will make the nose more straight. Okay?
Yes, sir.
Yes. So modified extracorporeal is the most versatile technique which is required in 9 out of 10 rhinoplasties, wherein in a very difficult cases, badly crooked septum only you will need extracorporeal. Extracorporeal is also needed. You must know how to do it. Don't be afraid of extracorporeal. But the modified extracorporeal is really helpful in reconstruction of the crooked deviated septum.
Sir, in the extracorporeal,
Yes.
how do you fix the neoseptum? Like with what suture do you fix it?
Yeah, usually at first I reverse it. I fixed it first. I
Okay.
make a solid L-shape assembly,
Yes, sir.
strong assembly. Now here we fixed first beam graft here,
Yes, sir.
and then I fixed to the lower end.
Yes, sir.
There I reverse. I
Okay.
put needle in the keystone area,
Okay.
temporary stabilization upwards,
Yes, sir.
but lower I fix it first to the intranasal spine.
Okay.
Once I fix it there, then fixation at the keystone area
Yes, sir.
is more important in the extracorporeal. See, the biggest drawback and the disadvantage of classic extracorporeal
Yes, sir.
is saddling at the keystone area.
Yes, sir.
So definitely in the expert's hand also,
Yes, sir.
2 out of 10 will have little bit saddling, which may not be appreciated by the patient. But you being a surgeon, you definitely know it.
Yes, sir.
So to avoid that supratic saddling, Professor Gubish was using the fascia lata,
Yes, sir.
which was taken from the cadaver,
Okay, sir.
but that we don't get in India.
Yes, sir. Because, sir, while doing a modified extracorporeal, sometimes accidentally you just might happen to, you can totally disjoint the septum and it
Yes,
becomes a
it is
complete
really difficult
extracorporeal.
technique. That's why this modified radical has come.
Yes, sir.
Now this is the free dice. The cartilage I told you I'll get at least 0.5 ml.
Sir.
So this will be filled in this depression.
Yes, sir.
So take the off ridge. You can see this radix area.
Not very clear, sir.
Shivaji, it's जरा इथं दाखव रे.
Sir, the picture, it's not in the center,
Yeah,
sir.
I'll show you.
Better, sir.
Yes. So you got it. So just put it like this
Yes, sir.
and inject.
दिख रहा है ठीक है.
It goes in the area where you want exactly.
Yes, sir.
Now you can appreciate the difference.
Yes, sir. Wonderful, sir.
But it remains in place, like it doesn't.
Yeah, it remains in place. Free dice remains in place. I have seen multiple times, even in my own revisions also. The free dice remains. It takes so well, it doesn't vanish.
Okay.
Free dice definitely remains. See,
It's very nice.
6-0 vicryl rapid. Now the skin suturing is done with the vicryl rapid. यहाँ ध्यान दे दो, wash.
So this is rapid vicryl.
Yes,
4060.
6-0. No need to remove also.
Yes, sir.
By the end of 10th day, it goes automatically. Because removing these sutures is really painful.
Yes, sir. So cast is put first or the pack is put?
Good question. Uh, there are no osteotomies,
Yes, sir.
so you can put pack first.
Okay, sir.
But when there are osteotomies,
Yes, sir.
definitely
The cast,
cast
first.
first.
Yes, sir.
There should not be lateral displacement of the vault.
Yes, sir.
माफ करो.
Something with the
projection comes, those saggy lateral alar walls वो अपने आप settle हो जाएगा, so you don't need a reduction.
See, my head may come in between while suturing.
So many people avoid suturing this lateral part also.
No, 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 no,
No?
nothing like that.
Okay, sir.
See, everything, the healing should occur by primary intention.
Yes, sir. But sir, dome wale part mein you don't
yes,
put anything.
domal, no
Yes,
suturing
sir.
in the domal part.
Yes, sir.
Because there is soft triangle.
Yes, sir. Soft triangle, right.
So these at least 2 to 3 sutures
Yes, sir.
in the lateral ala are definitely required, but definitely not in the soft triangle.
Yes, sir.
Now I will leave.
Yes, sir.
Not in this area.
Yes, sir. Right, sir.
last is remaining. So this should be your final picture.
So the camera is a little tilted right now.
Yeah. मेरोसिल ले लो. ये पकड़ो. Okay.
Wonderful, sir. Wonderful.
Very nice, sir.
This is the basal view. ये थोड़ा स्टिकिंग हटाओ. Nice.
Yes, sir.
No columnar retraction. Subtle suprative break point.
Yes, sir.
Straight dorsum. So this has to be the final picture. See how nice it looks
Yes,
compared to this one.
Yes, sir.
So
You'll have
there was a columnar retraction and the acute nasolabial angle was there.
Yes, sir.
You can see the nasolabial angle and see this nasolabial angle.
Yes, sir.
It is opened up.
Yes, sir. So he'll have to get his Aadhaar card updated.
No, it improves the function also of the nose.
Yes, sir.
Even the 3/4 view on this side is also looking great. Okay.
Yes, sir.
Okay. So now I will put the plaster. हे plaster साठी हे आता काढ बाजूला. Plaster you can show with the external camera. Now I will take the photographs, his post-op photographs, just quickly. रुको 1-2 मिनट, मैं फोटो लेके प्लास्टर ये डाल के फिर प्लास्टर करेंगे. शिवाजी हेकड़. माइक असू दे. कॅमेरा घे. So just quickly I will take the photos. stand there.
सैंपल कर आए थे मुंबई, याद है आपको? तो उन्होंने बैठ के किया था पूरा सेक्शन लॉन्ग बैक. बैठने में नहीं, बहुत सारे ergonomically सपोर्ट ले लेंगे ना विजेंद्रा की तरह. Kulkarni sir,
Yes.
there is a question that do you know any rhinoplasty surgeon in world who is doing rhinoplasty in sitting position?
Yeah. Yesterday I told one person from Italy. He's coming to Delhi.
When he is coming?
Yeah, he's coming in November. That Pragati Shubha is, I think, inviting him. Yeah,
Acha.
Enrico Robotti. Enrico Robotti does in sitting.
Okay.
Not exactly whole the time, but most of the times. Jelly. He does in sitting. See, sir, it is adaptation of the technique. That's it. And he uses, even the Kshitij uses prismatic loops. So with the use of prismatic loops,
You need not to bend your head,
yeah, you need not to bend your
neck.
so that you can shape them, design them in a way you want. Then squeeze out the excess water.
So 8 to 12 layers of this?
8 layers. 12 becomes too thick.
So it was looking thicker, that's why I asked.
No, it is
8 layers.
8 layers. And always fresh plaster every time.
Yes, sir.
The
So do you change in between sometimes after
No.
osteotomies?
No. See, now after so much of experience,
Yes, sir.
and I do plaster myself,
Yes, sir.
my plaster never becomes loose. Literally, you have to pull it out. On
So-
7th day, it is also so firm.
Yes, sir.
It is not at all loose.
No, sir, sometimes it gets dirty after 2 days. Like if you've done a,
No, if there is a lot of there is a good hemostasis,
yes, sir.
it doesn't get dirty.
No,
It
sir,
becomes
external
dirty with the-
osteotomy sites, from there some oozing
No,
will be there.
I take sutures at the osteotomy site, so
Okay,
there is
sir.
no oozing.
So usme there is no scarring on that?
Nothing happens.
No. Okay, sir.
It is imperceptible, absolutely.
Yes, sir.
Next case, literally hurry up. एकला इन्सिजन बसला पाहिजे तर 4 पर्यंत होईल. For the next case, literally I have to be very quick. I was telling my assistant, be very quick. शिवाजी तू जा, ते मी बघतो, तू पुढची ट्रॉली लावायला लाग. Next case photos, can we get it on the display so that before induction of the case I will explain everything.
I think
काढून द्यायला लागत नाही.
Sir, have you applied tincture benzoin before putting this
Yes.
elastoplast?
Yes. Tincture benzoin mainly on the plaster and little bit on the skin.
It sticks. The whole thing you will remove after 7 days.
Yes,
And the splint also. No?
everything.
Yeah. You didn't put the Mirosil string with the string without
No,
string?
without sting.
Without string.
Because the nose is closed, no, in the front.
Okay.
So string का कोई मतलब ही नहीं है.
हाँ, okay.
हे दे मायक्रोपोर दे तिथलं और एक दे दो
So Mirocell तो you will remove after 2 days.
Mirocell after 48 hours, yes, on Monday. और दो
Since there is no oozing, there is no bleeding, field is absolutely dry, still do you give these tranostate or something?
Yeah.
Tranostate?
Not now. Nasal spray, no?
No, not the spray, sir. Injection,
Trenexa,
injection
Trenexa,
Trenexa,
No,
injection.
no, not needed.
Okay.
Not needed.
Okay.
All these are support.
Hello. Good morning, ladies and gentlemen. Welcome to the 17th Back to Basic workshop. We are honored and privileged to be at the receiving end of a gathering of such intellectual magnitude. First and foremost, I would like to extend our warmest regards and welcome to our esteemed operating faculty, Dr. Vikas Kulkarni, sir. I was first exposed to Vikas Kulkarni, sir, back in Udaipur, where sir not only performed very magnificent surgeries, but also answered all our very basic questions and sometimes very silly questions as well, with great patience and clarity that had a very lasting impression on all of us. We met sir back in Mumbai also for SleepCon, where this workshop was planned. We are very grateful that sir spared so much time for us and did all these surgeries for us. Without any further ado, I would like to request Vikas Kulkarni sir, along with the organizers, Dr. Sanjay Agrawal sir, Dr. S.P. Dubey sir, and Yamini madam, sir, please do come and light the ceremonial lamp and inaugurate this ceremony. Without any further ado, I would like to request Vikas Kulkarni sir to please come on the podium and say a few words, sir.
So good afternoon, everyone. It is my pleasure to be with you all today on request received by Professor Dubey sir. So actually I was very happy when he invited me to Bhopal. Actually I'm coming to Bhopal for the first time, a really beautiful city. And one of my very close friend is residing in this colony only. I had met him after such a long time. So he is not a doctor, but he is my engineering friend, Dr. Rajendra Patel. So yesterday, actually, it was for him also, it was a very short visit, but I met him after quite a long time. He's a businessman over here. So when everything, and he stays out of India for most of the times. So when everything got confirmed, I contacted him and said, "Are you there?" He said, "Yes, I'm there. You do come." So with this visit, I met my friend after so long time. I met sir, and I could operate such a nice cases. So I'm very happy to be here today with you. So in the rhinoplasty, see, every ENT surgeon must learn this procedure, must, because the septum cannot be created unless you have its three-dimensional orientation. And the three-dimensional orientation of the septum comes only after its complete exposure. So once you expose it from above, then you will come to know what is high deviation, how it is oriented, how it needs to be corrected. And the most important part in breathing airway is the nasal wall and the nasal angle. So if you have a nice projecting nose, the nose which looks good also functioning good, that is for sure. No, जो नाक अच्छी दिखती है वो काम भी अच्छा करती है. The nose which is not looking good is not functioning. So you have to make the nose which is aesthetically better as well as functionally better. And none other than ENT surgeons are better knowledgeable, better equipped, better qualified than to do this case. We were not doing it, that's why the others were doing it. Now we are into it, we are claiming our area back, and really we are in the driver's seat now, or not in India but all over the world. And the credit of all this goes to Professor Gubish. Professor Gubish, he shown to the world that functionally nose is a functional organ. So that should look better, but it should function well also. So he emphasized the importance of all these nasal wall area, nasolabial angle, all these angles and aesthetic appearance. So and he taught all of us. He is so kind-hearted. When in the peak of his career, he was coming 2 times in a year to India. He was having good friends like Professor Pusalkar sir, and he was Virendra Gaisa's father. So he was coming to Pune, to Mumbai, to all of the places in India, Amritsar, Delhi, and he was teaching to the Indian faculties. He was inviting us. We were staying there for 1.5 years, 1.5 months minimum. So we never felt that we are outside India. So he saw that we learn, we take away something. And he always said, the knowledge which you are gathering from here, you always pass it to your friends. So the moment, see, don't hide anything. The way you will explore self, there is self-exploration also. So you go on teaching and you will also be more knowledgeable. So like that, for last 10-15 years, there is a boom in India of learning rhinoplasty. Then a lot of workshops are happening, and there is no much gadgets are required. There are no much serious complications. It is easier technically than the skull-base surgery. See, only thing is you should be brave-hearted. You should not be afraid of complication. See, complication is a part of surgery. Always speak with the patient. Know your limitations. Call somebody. Learn from him. See, assist one-to-one at least 10 rhinoplasties. At least 10. Then you will see, looking at the screen and looking directly in the OT, rhinoplasty is a way of difference. See, the most learned student in today's workshop are Divya and the fellow Kishan. So because they are assisting me. So the best position in the auditorium is assistant's position. So if you want to really learn into rhinoplasty, go and assist the people. See, we always welcome you. So go, stay there, assist 2-3 cases, follow them. I was following passionately for Virendra Gaisas for 5 years. He came from Germany. He is my friend. He came from Germany in 2005. Initially, I was going to Pune. Then I was calling him for my cases. So we both were learning. Then on one fine morning, he said, "Why you don't go?" I said, "I can go, but financially there is a lot of burden." So Gubish said, "No, let him come first for the workshop. Then he come as a fellow." And I said, 2 times I cannot go. I'm not that much rich. By skipping the practice and 2 times foreign trip is not possible. Suddenly in March 2011, I got call from Virendra that 2 fellows from Brazil are not coming, and Gubish has called and he has specifically said that one guy is behind me for last 2 years. Can he come on such a short notice from April? I said, I can go from tomorrow also. No, that is not an issue. Let him, because after 45 days there was a workshop. So in a one trip, the workshop usually happens in last third week of May. So in the one trip I was able to assist him, see him as well as the workshop. So in those 45 days, I saw almost 81 cases. And that really, that was really game changer. I saved my money. I went with Professor Belal Davar from Belgaum. So we both were staying together. 45 days we were there. So I saved lot of money, and while coming I purchased full Medicon set, and Gubish was so happy. He was knowing I'm not so well financially, but he is struggling. So I purchased whole Medicon set along with loop, everything, and I gave order because workstation was not available at that time. And I came to know that initially 5-6 घंटा लगने वाला है, 5-6 घंटे के लिए अपने को कोई एनेस्थेटिस्ट मैनुअल वेंटिलेशन पे महीना नहीं मिलने वाला है, क्योंकि एक पहले केस के लिए आ जाएंगे, दूसरे केस के लिए कोई नहीं आएगा. तो मैंने लालच उनको दिखाई कि आई एम गोइंग फॉर द वर्क स्टेशन. तो वर्क स्टेशन मेरे गांव में नया था, स्मॉल सिटी, स्मॉल टाउन. तो वो दे बिकेम रेडी, दे ऑल्सो दे वर रेडी टू हैंडल इट द वर्क स्टेशन. तो मैंने वहीं से वर्क स्टेशन का ऑर्डर दिया, इयॉन मेड का सेट लिया. मैं 10 लाख डाल के ही ये मैदान में उतर गया पहले ही इन 2011, क्योंकि अभी पूरा डूबना है या ऊपर आना है. तो एंड आई स्टार्टेड फॉर फर्स्ट 50 cases. इट वॉज रियली ग्रेट स्ट्रगल. I was calling daily to for every case to Virendra, to Kshitij. Kshitij also went after me. Then I was emailing photos. At that time, WhatsApp and nothing was there. I was emailing photos to Gubish. I was requesting his secretary to show those photos. But he was kind enough. He was replying in 2 to 3 days. I was getting reply. So I was planning case after 15 days. So I was collecting all the information. I was reading everything. Even my kids remember that journey. They were saying you were the whole night. In the morning I was opening the Daniel's book. I was reading, assessing. So if I can do it, you can also do it. What I want to say in short is, if I can do it, anybody can do it. So don't leave your dreams. And definitely first 50 cases are really difficult. Take assistant. We are there to guide you now. Attend maximum workshops, assist in a lot of cases, and make the daring and start doing the first case. After 10 cases, initially for first 10 cases, your staff will also say, why you are doing, छोड़ दो अभी, ये क्या करने की जरूरत है, कम है क्या practice. So all this you will listen, but after 50 cases, everyone will start enjoying. You will also start enjoying, and your journey will start. So venture into it. It is really a good branch. Reconstructive surgery is there, and you will be very happy at the end. Thank you.
Thank you, sir. I would like to request Sanjay Agrawal, sir, to come and say a few words.
Yeah, I agree with Vikas. I first called Gubish to Indore in 2000, and we went in 2014. I also purchased the whole Medicon set, but I could not dare to continue. Again, I am motivated. Frankly, I thought it is not my cup of tea, but no. We attended so many. All Viren courses. Viren is a dear friend. Shiti, we have invited here. And we attended so many courses, cadaveric, all preparation we did, but then I said I am happy with ear and sinus work. Recently, he brought me in laryngology. So I think maybe in near future we'll come to you. And I welcome all the delegates. Yeah.
Very few people who are doing it, rhinoplasty. So market में इतना ear surgery के पास window shopping के लिए सभी के पास जाते हैं. Hello. Rhinoplasty के लिए
3-4 लोगों के 5 लोगों के पूरे स्टेट में देर आर नो 5-6 लोग हैं जिनके पास वो पेशेंट
Yes, you are correct. So in Indore only 3.
More and see the insurance by introduction of more insurance company, the insurance sector has become big. किसी का धंधा कम नहीं हुआ. So our aim, we Virendra Kshitij were talking in the same way. Unless lot of people are talking about it, the society will not come to know that it is job to be done by ENT surgeons. Ultimately, this job needs to be done. मेरा केस आपके पास आ जाएगा, आपका किसी का उसका तो मेरे पास आएगा. So
Correct.
unless lot of people are
No,
doing
like in
this
Sarafa, all are
awareness,
jewelers.
Yes, yes.
That is not a problem. We are also the founder member of the association. It was created, we were sitting in a coffee shop, you might be there also. And yes, I am also motivated, and we see faces who are interested only can come on a working day. So thank you, Vikas. Thank you.
Now I would like to invite Dr. S.P. Dubey sir for his vote of thanks.
So let me tell you the other side of Dr. Vikas Kulkarni. Now he is making a hospital in 30,000 square feet area, ENT hospital. So he is such a rich man now after doing 1,000 rhinoplasties. And his wife is ENT surgeon. His son is doing ENT PG. His daughter is ENT surgeon. The whole family is dedicated to ENT only. And to tell you, from Sangli, the place to which he belongs, to be precise, the Ishwarpura, previously it was Islampura. So from coming there to here in Bhopal, he has to catch a bus in the night, get down in Mumbai. He has got his own home in Mumbai, so he is such a rich man. And after that, he took a flight from Mumbai to Bhopal. So ultimately, it's a lot of pain, lot of, leaving the practice and coming here to only teach us. So thank you very much, Vikas. You make it possible for us. And what the story he narrated is really inspiring to you. Because so many surgery, if we see people say complications, people say so many difficulties during surgery, results are bad, complications are there, but he inspires you by telling his journey in a very simple way. That will able to take you rhinoplasty as a career. And he rightly said, most of the rhinoplasties are previously done by plastic surgeon, aesthetically good nose, but functionally bad nose. We are the people who knows how we have to make the nose functionally and aesthetically better. And that is why they are there. Gubish was there for us, for him, for Virendra, for Kshitij. Now all these, Kshitij, he himself, and Virendra all becomes the Gubish for us. So these are Indian Gubish. You go to them, learn them. They are happy to, facilitate you. And I know that all the residents are very rich people. All the young doctors are getting good stipend. They are coming in cars. In our time, we were seeing in hostels, there was motorcycles were there. Now cars are there. So, there is no dearth of money if you have learning passion. There are teachers who are going to make you learn the things. And I thanks from the bottom of my heart, Dr. Sanjay Agarwal, who is a co-organizer always with me, Dr. Sudhakar Vaidya, he is a past president AOI as well as Asia president, doing so many academic activity in Ujjain. He is kind of Dr. Yamini Gupta ji, who recently started new rehabilitation center at Indore, which is free of cost. It was a news of paper, very innovating work she is doing. Dr. Kirti, who is a new Turk in rhinoplasty. If you want to learn something, you can go to her also. She is very much into
he has deviated nasal septum also on the right side, and also the deviated nasal dorsum on the right side. So he has facial asymmetry. I'll show you the external photographs. He is having deformed concha on right side. Also he has huge submucous cleft palate. So he has hypoplastic malar eminence on the right side. So this side is less developed, left side of the face. So that's why it has shifted on this side. So I am infiltrating first. So in this case, again, whether to do osteotomy or not is always a question mark in a case of asymmetric nasal dorsum or the crooked nose, because too much narrowing or the nasal bones always doesn't give symmetric nose, but it enhances the deformity. So not doing the osteotomy or doing just the root osteotomy and keeping the tip wide will be a better choice than doing the osteotomy. So if at all because the root is deviated, I will show you in this case, because just for doing root osteotomy you can do it with the piezotome. Piezotome is really good instrument, and I may need piezotome in this case. So just routinely I have infiltrated. And I will be doing intranasal infiltration in the scroll area.
Sir, which solution you have infiltrated just now?
Pardon?
Which solution?
Ropivacaine with adrenaline. So in the scroll area I have infiltrated.
Sir, there is a question, what is the advantage of ropivacaine over xylocaine or
Ropivacaine is a long-standing anesthetic. It is better than bupivacaine. It is a next derivative than the bupivacaine. Also, the cardiac safety of the ropivacaine is much better than the bupivacaine. So it is a long-acting, and some say it has some vasoconstrictor action, but the advantageous point is it is long-acting, and it is safe compared to bupivacaine in relation with the cardiac safety. So these are the 2 points which make us to use the bupivacaine. मगाशी माईक कुठं लावला होता? मागं लावला होता की? हां, तिथंच लाव. हाताला अडचण.
What's the concentration which is used?
Yeah, it is 0.2% ropivacaine. It is comes as a vial, and I add adrenaline to it, 0.2 ml in 20 ml. That makes 1 in 1 lakh. 1 in 1000 0.2 ml adrenaline is added in 20 ml of the ropivacaine. So that makes 1 in 1 lakh ropivacaine with adrenaline. So you get advantage of adrenaline and advantage of ropivacaine both, and it is preservative free because you are making it fresh and using it fresh. Pen de do jara. So now I will explain the photos. Before that, are we going to show the yesterday's case photos? Divya is there. Okay. Okay, so this is one here, yeah. So this is the patient's preoperative photographs, all the classical 7 views. So you can see, I always ask the patient, what is your main difficulty? Whether there is a breathing difficulty is more, or you have come for crookedness.
And most of these young male will say that they have come for crookedness, because breathing difficulty is not their main issue, but this crookedness or the deviated deviated nose is their main complaint. So in the front view it is quite obvious, even you can see the small pinna on the right side. The malar eminence is also hypoplastic on this side. He has excessive nasal twang in his speech. There is rhinolalia aperta, because of he's having severe submucous cleft palate. He is not at all operated for any cleft surgery, but he has developmental submucous cleft palate. So we are facing such case. Our aim is to give the good looking nasal dorsum. So always never overcommit to the patient. Explain them the facial asymmetry, show them what are the points which are correctable, which are not correctable, and in the case of facial asymmetry, always commit less. Say them we can give maximum correction, we'll try to give maximum correction, but overall face is asymmetric, not only the nose is evident. So in this case of facial asymmetry, even in the basal view you can see the classic axis deviation, in the helicopter view also you can see classic axis deviation. In the lateral view it looks fine, the dorsum is straight, running point of nose is straight, he has a thick skin, but that is advantageous in this case. The tip is wide, that is also advantageous, and we will try to keep this tip width as wide as possible, equal to philtrum width or even more than the philtrum width, and we will try to make the nose look straighter. So let us see. Any questions?
Chalo.
So basically we have to look face as a whole, not
Yeah,
only the nose.
yeah, not only the nose, yes. Are we showing yesterday's cases? Are they whether they are there on screen? Okay, we'll discuss about it at the end, about yesterday's case. So just I will wash up. Painting करू ना, घे ना चल. हाँ? काय झालं? ऑफ कीजिए माइक. हाँ, तब तक मैं कुछ पानी पी के आता हूँ. नहीं, रहने दे दो, रहने दीजिए, मैं थोड़ा पानी पी के आता हूँ तब तक. ड्रेपिंग झालं की मला सांग, मी आलो तवर. मी जरा कुछ खा रहा हूँ मैं. आपको बताना पड़ेगा क्योंकि अंदर उसका डिस्प्ले नहीं आता है. सर ये स्टैंड कौन बनाता है?
हेलो, ये कहाँ से चालू है?
Hello, Suttu bhai.
Hello. Hello, am I audible now?
Yes, yes.
Yeah. Now
You are audible.
We'll show the yesterday's case photographs. So I'm just in the preview room. हाँ वो छोड़ दो अभी उसको, उधर नीचे वही गया है। नहीं ये छोड़ो ना।
अंदर भी लग गया है कल वाले।
नहीं अभी post
Yes,
of photos
we are
तो इधर ही
we
है
are
ना,
able to
post of
see.
photos तो इधर है। Yeah, so he is having definitely the crooked nose, crooked dorsum. Then there is caudal septal deviation, huge caudal septal deviation, and he has saddle nose, cartilaginous saddle nose as well as low radix. Now when I explored his nose, the problem was he was having very badly fractured nasal septum, which was the anteriorly fractured septum as well as the fractured and deviation of the septum in the keystone area. So it was not at all possible for me to reconstruct in situ or do the modified extracorporeal. So otherwise he would not have been happy at all if I would have tried, and I was knowing this case as a difficult, so this was the case needs more times, that's why we took it yesterday. So I opened the case, I took out the whole septum, and I made the septum straight by applying the ethmoid splint. I reimplanted the septum, L-shaped septum in the keystone area and in the anternasal spine. But after that I still found that there is residual saddle, and the patient will not be happy if I leave that patient like that, because the radix was low, he was having saddle, and his expectation was he should get rid of the saddle. So we harvested the 9th rib, and the distal tapering portion of the 9th rib is really nice, and it gives it itself is a contoured only thing, it is having inherent warping, so you have to give half cut on its inferior surface and on the right concave surface. So accordingly you can make it straight and you can reimplant it from radix to the tip, and this is the final picture. Case went for 5 hours, so there is a lot of facial edema. There is some dorsal irregularity, but that is because of irregular facial edema. Next. Here, now you can see the difference in a thick 3/4 view. So he was having obtuse nasolabial angle. So just to correct the obtuse nasolabial angle, I have put again the septal extension graft, then the dorsal augmentation, and the neoseptum is L-shape assembly is created. Next. और एक है lateral view में. हाँ ये वाली. ये वाली. So this was the final outcome, and I suppose he should be happy, but I am sure this will remain stable. There will not be any change in the final outcome.
What is the marking on the forehead?
No, that is not the marking. The solid rib which I have placed there, it is sutured to the ethylon, and that is taken out through the skin, and that is the support to that thread. You can see the black thread also coming out in the midline. So the solid rib which I have placed on the dorsum, that is radix to tip area, for the support of that solid graft, that suture is there. That is a usual technique when you put the DCF, dice cartilaginous fascia, or the solid rib on the dorsum. It has to be supported at the top as well as to the cartilaginous dorsum. So to the cartilaginous dorsum it is supported with the horizontal mattress sutures, and at the radix it is taken out and it is stabilized with the suture as well as that sticking. Okay, now I'll start with the next case.
ये पीछे लगाओ. गाउन गाउन किधर है? काय म्हणा? आता कुठं आहे बस आमच्या असं तर कॉपी अर्जंटच्याकडे असेल आहे. हेडलाइट दे शिवाजी टेबलवर घे. So when you want to begin the rhinoplasty journey, at least start analyzing the faces of your family members, your colleagues, your friends, your staff. So what nose they have, start imagining what could be inside them. Yes. Hello. So the analyzing is the most important. कोण होतं फोनवर? So you start looking at the colleague sitting next to you, and if his nose is good, just keep on imagining what good can be inside, whether how the strong cartilages is, what is the skin cover, skin envelope. So always start analyzing each other's nose. Start imagining even if he is not your patient. जरा टेबल खाली गेले जास्त वर झाले.
Hello, good afternoon sir, I am Dr. Nijin speaking.
Yeah.
Sir, do you always use scalpel for shaving or sometimes you use clipper?
No, I always use scalpel. Sir told me now about the wheat cream. So next time I will be using that hair remover cream. Let us see.
Okay, thank you sir.
Okay. So as usual, the cut केलेत ना? हे कुठे आहे? शिवाजी. डबल हुक नाहीये.
पहिला डबा आहे का तो कालचाच आहे ना डबा So we'll just take incision at the lower border of lower alar cartilage.
Yes, sir.
नको 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 सक्शन करो जरा soft triangle के
Junction of the hearing and non-hearing area.
Yeah.
I think in routine septoplasty also people can practice this incision and elevating the vault.
So the combination of sharp and blunt dissection, you are on the nasal dorsum. शिवाजी जरा सेंट्रलाइज करे आहे ना सोड डबल हुक है सक्शन
मेरे को बाद में
So the incision is taken.
Yes.
The narrowest portion.
Yes. You always take inverted V.
Yeah.
Because incision is given adequate, so
Yes.
immediately the whole vault is up.
Yes.
So I mean initial incisions are very important.
incision should be of proper depth. It should not be the incomplete incision. सर वो केस को एंटीबायोटिक दे दिया पोस्ट ऑप, और कल वाले केस को सुबह?
हाँ दे दिया सर सुबह।
ओके।
थोड़ा सेंट्रलाइज करना बेटा, वीटम शिवाजी, ताकि अंदर का दिखे। वेरी गुड। Now we are able to see the nasal bone.
Yeah.
And this time elevation is very good, no bleeding at all.
Yeah.
Mostly.
So I have gone adequately laterally on both the sides in a subperiosteal plane.
Yes, sir.
Just to find out the obliquity of radix, and
Sir,
radix is reasonably straight. Let
सर
us see.
थोड़ा सा सर अंदर दिखाइए सर, थोड़ा सा ऑब्लिक है।
थोड़ा सा oblique है.
हाँ।
On this side to this side.
नहीं,
Let us see after taking out the septum. हाँ हाँ.
With the Vitom you please show inside.
Okay, okay.
थोड़ा एडजस्ट कर देना शिवाजी। ये अब सही दिखा बिल्कुल अंदर तक।
Yes.
थैंक यू सर।
कर फिट कर आता टाइट कर या पोजीशन ला।
फिर बेटा हिल गया थोड़ा सा।
ठीक है सर, अभी यहाँ तक का तो हो गया।
हाँ हाँ।
I will just go ahead with the tip.
ओके।
पकड़ो ये।
So here you, I mean, cut the Petengi ligament first.
Yeah.
Then
So
you will.
in open approach rhinoplasty,
Yes.
those who are doing closed, they can find out, they can preserve the Petangi. But here we first go through the Petangi only.
Okay. Sir, there is a question that you do close rhinoplasty also.
No.
No.
Close, yeah, people are demanding close.
In our area, Dr. Basir is doing so many cases with close.
Professor Gubish initially started his journey in a close, then finally he settled in open.
Okay.
Because lot of difficulties, lot of deformities. See, the case selection is most important in close.
Yes, sir. So I mean, release the scroll area
Yeah,
also.
release the scroll area.
Scroll area also.
Yeah. Now I will be, see the steps in most of the cases
Are identical.
of crooked septum are identical. Now you have to find out the septal angle. ये पकड़ो.
So,
Yes.
I mean, just separating the upper lateral
Yeah,
cartilage.
upper lateral from the dorsum, I will find the plane easier there.
Yeah. So this time again you went towards the convex side.
Yes.
Yes.
Convex side always first.
Always first.
Because if the tear happens on
Yes.
that side, you will be more cautious on the concave side while
Right.
elevating.
This you always do like this.
Yes. Just below the nasal bones.
Yes.
Always separate and
With-
do the pyramid in osteotomy with the scissor on this side. छोड़ो ये छोड़ो. Now this is the normal size, so I will do close
To the
to the
midline.
midline. Yes. So at least half I could do it. Okay. See retractor there. Till the medial canthal line. Till the medial canthus you have to go.
Osteotomy
Osteotomy, pyramidal osteotomy
till the medial canthal
till
line.
the medial canthus.
Sir,
Ah,
you always do a paramedian osteotomy?
yes.
Okay.
There are few indications where I don't do,
Okay, sir.
but always do paramedian. That is the thing which you cannot do afterwards. That is to be done when everything is stable.
Right, sir. So sometimes there is no, the bony vault is all right. It's like
Yeah, when there is
fine.
no need,
So then,
I definitely don't do it.
okay, sir. And so the paramedian osteotomy you take up to the intercanthal line?
Yeah, up to the medial canthus.
Okay.
That is its ideal landmark, no? Same steps, I am not saying anything when I am doing. So just please bear with me.
Yes, sir.
Now he has a submucous cleft palate. So I suspect he is having very weak vomer. No, vomer is good. I elevated on one side very well, no tear, nothing.
Yes, sir.
So 5 mm osteotomy with the scissor and completion osteotomy with the 5 mm osteotome. There is a bleeding from one emissary vein. एक छोटा गॉज ले लो, नहीं एड्रेनालिन दे शिवाजी, ड्राई ले लो, उसके ऊपर एड्रेनालिन डालना है.
एक एकदम छोटा बोटा एवढा बनव, त्या स्पेसमध्ये जायला पाहिजे. Section there. C retractor. सीझर बघते मी. Okay, now I will be dissecting in front of the antranasal spine. On both the sides. Now another technique in this case is root osteotomy and unilateral spreader on the concave side to camouflage the dorsal aesthetic line. On the concave side you can do double spreader also and no spreader on the convex side. So let us see after exposure and taking this assessment of the septal deviation, let us plan how to reconstruct it. शिवाजी एक खाली ठेवायला दे ॲड्रिनलिनचा गॉज. इथं मला एक गॉज ठेवायचा आहे. नाही जरा मोठा कर. Septum is almost fractured parallel to the maxillary crest. You can see that fracture line inside. You can see that fracture line?
Yes, sir.
Yeah. And it is torn also. Hammer. खालचं सोड वरचं धर. Okay, I have separated the septum from the maxillary crest. ये पकड़ो. And I can see there is a separate piece of cartilage, see this, which is absolutely torn at the maxillary crest. So I will take this out piece and I will try to fix the assembly in the midline anteriorly. So this was the piece of cartilage which we have got.
Yes, sir.
And once we take this out, see the crookedness has significantly decreased. The moment you bring the septum in the midline with some amount of root osteotomy, rest of the septum is intact. I will use this piece for spreader, let us see, because we don't have much of the cartilage, because he is having submucous cleft. There is a paucity of cartilage during development and there is some inherent deviation. You can see this. You can see this deviation.
Yes, sir.
So we'll try to correct this deviation in situ with the ethmoid splint in situ. Let us see. First we'll fix it to the antennatal spine. If it straightens, it's all right. Otherwise we'll put the splint. We don't have any material for splint also. Let us see. First we'll suture it to the internasal spine and let us see what happens.
So you're not changing the height of the dorsum, right?
No, I'm not changing height.
You're keeping it the same.
Yes,
so
I'm saying keeping it same.
how do you
And
decide
I'm definitely I'm not going for the modified extracorporeal also.
So-
I'm preserving this L-shaped strut as it is.
Yes, sir. So
Because
when do you
if
decide?
at all, yeah, if no, let me complete.
Yes,
If
sir.
I want to go for extracorporeal, modified or anywhere, I will need more cartilage which is not there.
Yes, sir.
ये पकड़ो. So I will hold this. I will take out the core of the septum and let us see. Ink. Can you see the marking which I am making?
No, not
Okay,
exactly,
just
sir.
1 second.
So we'll be able to see the left side better, I think. Yes,
Okay.
that is more visible.
Now,
Yes, sir, we can see your flag knife. So you're following the same principle as you told in the first case.
yes.
Okay, sir. So you always mark and then cut?
Yeah, this definitely, because this step is very crucial.
Yes, sir. So you're leaving about 1 centimeter above?
Minimum.
So,
1 centimeter at the narrowest
yes, sir.
and 2 centimeter at the widest behind.
Okay, okay.
लाइट बदल रहे, बैटरी बदल रहे शिवाजी. Just my headlight battery has turned off. Let me change it.
So, so I was asking about the height. So when do you decide that you want to, like in this, there is no other deformity. So
Yes.
if you want to increase the height,
No,
what do you
I'm
consider?
not at all going to increase height of the dorsum. Dorsum is straight, right from radix to tip.
So,
So that
because
is
in
for sure.
in the lateral view you assess that.
In the lateral view, yes.
Yes, sir.
So this is one more piece of cartilage which we got. Ethmoids are really weak. I tried to harvest them along with this. I will suture this and we will put some batten graft, cartilage batten graft for this deviation. But after releasing, this has reduced.
Deviation has reduced.
Deviation has reduced.
Yes, sir.
So let me suture it to the intranasal spine first, and then we'll put some batten. Batten will support the weak septum also. We have good material for putting the batten graft and the spreader graft. हे घे मोटर आणि हे. see the nasal spine is not so well developed. Huh? You can see
Yes, sir.
compared to previous cases. Nasal spine is not so well developed. This is so traumatic.
Sir, your needle is 18 gauge, na?
18.
18 gauge. And this attachment will fit into any straight handpiece.
Any handpiece. Any straight handpiece. Ethylon.
ये आपको मेडियन से खरीदना पड़ेगा. इसको बुलाओ का थोक में. हाँ, ये भी सही है.
This is called as hack adapter.
Hack.
Hack Sebastian Hack ने डिजाइन किया है इसको.
अच्छा, Sebastian Hack, okay.
Okay. Now we'll suture the anterior septum to the spine. Tip, 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 tip.
I think by your technique, Vikas sir, there is a very less chances of breaking the spine because
yes,
we go tangentially.
Very less chances.
Very less chances. And you always have a very good hole.
Yeah.
And very good support of extra bone over the hole. But this suture technique, it is only by combination and seeing the...
Yeah, a lot of other surgeons facing the difficulties of making hole.
So you this time you have not made any hole into the spine?
No any notch.
No notch because
no
the spine
notch.
was not very prominent.
Yes.
Because sometimes other surgeons say that you fix onto the right side or left side, one side of the spine.
No, 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 sir, no. It has to be in the midline.
It has to be in the midline. Okay.
See, sir, it is becoming straight. It
Yes,
has
sir.
become straight.
Right.
So no need of any splint also. So moment I will tie it to the septum, spine, it will, I am sure it will be straight.
Hello.
Hello.
Sir, there is a question that spreader graft you will use in this case or not?
100%.
100%.
Maybe unilateral. On the concave side.
Okay. And osteotomy तो for sure.
हाँ ऑस्टियोटोमी भी करूँगा अभी उसका अभी मैंने देखा once I make this septum straight then I will decide about the osteotomy.
Okay, sir. 4 times.
4 times, yes.
4 passes है. और होल इतना बड़ा बनता है कि चारों बार आराम से धागा चला जाता है.
और उसको हम रिपीट भी कर सकते हैं.
क्या कर सकते हैं सर?
रिपीट भी कर सकते हैं अगर धागा टूट गया कुछ हो गया.
हाँ. But you are using.
Sir, I have taken it on one side, other side.
Yes,
देखो.
other side, yes.
You noticed it?
Yes, yes.
For the last pass, I just shifted it to other side.
So what if you fix the septum to the
periosteum?
Yes, sir.
Madam, do you feel it will be stable?
No, sir.
I have seen in few cases where spine is not there and the revision cases
No,
are
when it
there.
is not there, then it is all right.
Ah.
But when it is there, why?
Why? Yes, yes.
See, you should have better stability, no?
Yes, sir.
We have seen a few times in demonstration the surgeon is not able to drill the hole, and at the last he has fixes with the thick soft tissue there.
So do you fix for when you do septoplasty also you fix it like that?
Yes. So I have taken it on one side and I have achieved the straightening of the septum. My septum is absolutely straight, central and in the midline.
बल्कि उसमें तो what we
दिख गया ना? So my septal correction is over. पकड़ो. Now let me think of the dorsum first. Bony dorsum. Let us see how to. First time.
Now I want to take this piece of the cartilage of the bone out, so I will do unilateral osteotomy.
Sir.
And I will do root osteotomy. I will shift the root on this side.
Yes, sir.
So the root I will be shifting on this side, and only this piece I will mobilize on the outwards, and I will put the spreader. So this part, I will use 2 long spreaders, double spreader, or one with this and one with this, and I will be using again the septal extension graft for better projection. So we have enough material. So there was a bleeding from emissary vein. Let us hope it has stopped. No, not yet.
So sometimes you can use bipolar, sir, or you can use some emissary will not stop with bipolar. Or we can use some diamond burr or your polishing burr.
सर क्वार्टरी चाहिए,
मिलेगी सर.
क्वार्टरी लगाई है,
लगा हुआ है ना?
लगा हुआ है इसे.
ओके.
ये पकड़ो जरा, बघूया ना बायपोलर, बायपोलरनच बघू. वो कोलारेडो भी दे दो, वो निडल दे दो. आई विल यूज मोनोपोलर फर्स्ट. मोनोपोलर दे दो, लगाओ यार जल्दी. ये पकड़ो, होल्ड दिस. Ready? बायपोलर लगाओ. छोड़ो जरा ये.
ये पकड़ो. पकड़ो. छोटा दे दो, गॉज दे दो छोटा. ये निकालो, वो निकालो. और छोटा बनाओ, उसको छोटा नहीं बोलते. I'll just complete with the osteotomy.
Yes,
on
sir.
one side.
Sir, external pressure from the on the infratrochlear vessels will help.
No, it with the pressure it stops.
Sir.
ये पकड़ो जरा, सक्शन पकड़ो. निकालो. Definitely it stops with the pressure. The moment I go inside, it starts, it opens. It is purely emissary vein.
Yes, sir, it is all venous blood.
Yeah, ये काटो जरा. पकड़ो इसको, एड्रेनालिन ले लो. Ink again. So I'll plan my osteotomy incision. So the root is oblique like this.
Yes, sir.
This is the medial canthal line.
Yes, sir.
And this is pyriform aperture. This is nasolabial line.
Yes, sir.
And this is our paramedian osteotomy. Okay?
Yes, sir.
So this part I am not at all touching, only this root I will shift to this side. This is normal, this nasal bone is normal. Only thing we want to bring it out.
And also I may trim some amount of nasal bone because here it is excess. In this region it is excess.
Yes, sir.
This corner it is excess. So let me mobilize this first, then I'll think of this. Hege. Cold water, blade, 15 number blade कुठे आहे? So for left side osteotomy, I will go on the left side. So I have taken stab incisions.
Audio visual, can we have PIP, picture in picture? Sir ka bhi, or how he is tapping? Audio visual. The picture in picture में एक सर का दिखाओ, सर जब ठोकेंगे.
So I am just scraping the periosteum at the incision sites.
एक्सटर्नल कैमरा से सर क्या कर रहे हैं वो देखना है.
So I am scraping the osteotomy incision.
Yes.
So that will mobilize all my vessels with the Gauze.
थोड़ा जूम आउट करो, हाँ, ताकि हाँ टैप का ये दिखाई देगा.
So this is a 3 mm osteotome.
Yeah, this is 3 mm osteotome.
So you sharpen it every time you use it?
Say after 10 cases.
10 cases. Okay, sir.
See, it is really sharp, no?
Yes, sir.
With a few third tap, it should go inside.
Yes,
sir. How you sharpen it?
Sir, emery stone.
Emery stone.
So I have done transverse osteotomy.
Yes, sir.
And now I will do low to low. The green stick has happened, but I want full mobilization. Okay. We'll take this out. You got my point?
Yes, sir. So it will stay there only because
yeah,
of
with the spreader it will stay there.
Okay, sir.
We'll put the spreader which is going beyond.
Yes, sir.
That's why I did it only on one side.
Yes, sir.
And it is a single piece, big piece. See?
Yes, sir.
This is the whole piece which has fully mobilized. So we'll put the spreader which is going beyond up to the radix.
Yes, sir. So you don't do it on bilateral side
No,
like this, no?
no, not in this case. Not in this case, but I will mobilize the root on this side.
Yes.
I will do root osteotomy. Let me just take control of that emissary bleeding first. That is still there or not, I don't know.
I think
If at all it is there, I can take the control now because I have fully mobilized that nasal bone.
Yes, sir.
See, it has stopped now.
because of the mobilization, something has happened.
Yeah. So this is full mobilization, you can see.
Yes, sir.
Yes.
And now we are going to put the spreader in this part. And the root has also mobilized, see.
Yes, sir.
The root is also moving. So I may put 2 spreaders on this side. Let us see. The root has also mobilized. I will make osteotomy on this side also. I will press it on this side. I will make green stick on that on the right side, 15 number blade.
Emery stone.
Done?
Yes, sir.
It is mobilized fully.
Yes. Along with the root also it got mobilized.
Yes.
Now you can see the difference?
Yes, yes. Now we can see.
Yeah.
So when we were students, we were scared that you will get, if you open it up, you will get a rocker bottom deformity.
No, madam, nothing happens.
Right, sir.
Only thing, the biggest problem with the osteotomy is it should not be at different level.
Yes, sir. Means it should
So
be
you
flush.
should follow,
one.
it should follow that line low to low.
Yes, sir.
And it should not be a multiple pieces.
Okay.
So if the instrument, especially the hammer, see if you see the hammer,
Yes, sir.
this hammer is most important.
Yes, sir.
It transfers such a nice force. Third tap and it is done.
Yes, sir.
Yeah, it is fully mobilized now and it is straight.
Medion का ही है. Hammer.
दबाओ.
हाँ, मेडिकॉन कंपनी का है. महंगा देता है बहुत हर चीज.
Suction कम करो जरा.
सी रिट्रैक्टर पकड़ो. नको थांबलेलं आहे ब्लिडिंग. वेळ घालवायला नको आता चल. Just I am skipping my 2-3 minutes of putting the cold saline, and I am just heading towards the application of, because there is no much of a bleeding.
Yes.
I will trim all those excess. Let me put that thick piece of the cartilage.
Yes, sir.
ये पकड़ो. You hold that, I will cut it.
See at the exact where there is maximum axis deviation, there is thickened. So you can see it here. There is a thick spreader over here inside.
Yes, sir. Yes, sir.
Yeah.
That is deeper inside little bit.
Yeah, deeper inside.
So
where
that
I
will
want it.
push the nasal bones.
Exactly.
Right, sir. So you
I may put one more. And this upper lateral is excess. I will cut this upper lateral.
Yes, sir.
Because this is definitely excess.
Sir, will you suture the nasal bones with the septum again? No.
Yeah, I will suture. Not the nasal bones, but
the
this. I cannot suture the nasal bones.
Yes, sir.
But it is fully mobilized, see?
Yes, sir.
But only the septum is straight below and it is supported. That's why it is not sinking down.
Yes, sir. So you did not remove the vomer also?
No, no, I didn't remove anything. I removed the septum. I removed very less.
Okay. So that you maintain the support because you are opening
Yes,
up so much.
yes.
Okay, sir.
ये पकड़ो. Even I can think of doing spreader flap also on this side. So this is the excess upper lateral, the mucosa of which I have dissected. You got my point?
Yes, sir.
So this is excess. So instead of cutting, I will flip it down. Blade, 15 number, 11 number. So I given a partial cut, 1 minute, and I will fold it. It's really difficult to fold it and hold it. No, I have cut it. So the excess spreader flap, I would have got 1 mm more thickness over here, but it's all right.
Yes, sir.
Now we have one more big piece. So I will put one more spreader on that side.
Yes, sir.
And remaining I will use for the tip reconstruction.
So Indian skin is quite thick. So for the dorsum, you generally do you add anything else to hide any irregularities on the dorsum, or the skin takes care of it?
Skin takes care of it. That is boon in disguise.
Yes, sir. Actually, most of the time we are learning from the Western
Yes.
people, so they are doing that, but in our population, we really don't
Not
need it.
needed
most.
actually.
Yes, sir.
Hold it like this. Long needle. Long needle कुठे गेली रे?
Their mistakes surface out very easily. Ah.
ऐसा पकड़ो इधर.
सही बात.
Now you got true lateral displacement, no?
Yes, sir.
Almost by 3 mm. Now it is absolutely straight. If you see with the three-dimensional view, from the top, it is looking very, very straight. Complete mobilization and also the lateral displacement. Can you appreciate?
Yes, sir.
Maybe not. But it is
So
there.
it is actually very close up for us. So we are
Yeah,
only
yeah,
seeing
yeah,
the
yeah,
nose.
Yeah. See retractor pakdo.
So like this in this patient, the eyebrows are also crooked.
Yeah.
So, I mean, it is a very difficult proposition. So, do you take video consent and all that in patients?
I do take.
Okay.
At least in a difficult cases.
So,
see, if there is a proper counseling, usually and you are not committing anything,
yes, sir.
no overcommitment, then usually there is not a problem.
So, actually, this is a patient's unrealistic expectations.
Then you make them aware of what they have,
Yes,
and they will understand.
So you said na you send them away to other rhinoplasty surgeon, then if they come back to you, then you operate.
Yes.
That is a good point.
See, the difficulty is for mine is difficulty for everyone, no?
Yes, sir. So patient also, when he talks to two people, he'll realize
Yes.
what he should expect and what he shouldn't.
Yes.
Sir, in this you're taking the upper lateral a little higher than the septum or at the same level?
No, at the same level.
Same level.
Same level. See.
Yes, sir.
In fact, we have trimmed, no, upper lateral.
Yes, sir.
Otherwise, it would have come at a higher level.
Yes, sir.
The 2 mm I have trimmed. Actually, I wanted to make the spreader flap, but
Yes,
that was
sir.
too short for getting it folded.
Yes, sir.
Now, for septal extension, yeah, I will close this, no problem.
So in place of a septal extension graft, if you put a columella strut, will that not have the same effect?
See, the stability and the effect of septal extension graft
Yes, sir.
is far, far superior. All of us have stopped using now columella strut.
Okay, sir.
Purpose is same,
Yes, sir.
but the outcome is
Different.
different. See the septal extension graft in a closed rhinoplasty,
Yes, sir.
they put it in each and every case
Okay.
just to bring the tip up and at proper position. See, we are in an open case, you can do छोड़ो. You can do the tip sutures.
Yes, sir.
But in a closed case, it becomes difficult to put the tip sutures.
Yes, sir.
So that's why they start putting the septal extension graft, and that gave really good results. So everyone started using septal extension graft.
Okay, sir.
There are various names: TO graft, ANSA banner graft,
Yes, sir.
simply septal extension graft, depending upon its position, angulation, and purpose.
It also reduces the putting columnar graft and other grafts.
Yeah. The aim is to have a tip stability. Tip should not go down. There should not be parrot beak post-operatively.
Yes, sir.
पकड़ो ये और एक दे दो.
So like in the previous case also, sir, you put a septal extension.
Yes.
And you pulled up the lower lateral over the septal extension, so you got a height.
Yes.
Otherwise, conventionally, anybody else would have sutured it in the same place and then put a dome graft over the lower lateral.
So you get a natural tip, no?
Yes, sir.
You are getting natural tip.
Yes, sir. उसमें contouring becomes very difficult.
Yes.
नुकीला आ जाएगा एकदम से. इसके बाद स्क्रोल एरिया में डिस्कशन करने का यही फायदा है कि हमको डोम को ऊपर ले जाने में मदद मिलेगी.
I will be putting this whole septal extension graft on this side, long needle.
But with the septal extension graft, sir,
Yes.
suturing the lower where you are suturing and at what angle the lower lateral should be aligned so that the lateral contour of the
one more long needle. See, the lateral contour gets stretched the moment you bring it up.
Yes, sir. Okay, agreed. But still there is a lot of learning in the angulation,
Yes.
I think.
No, you should keep it perpendicular. I am seeing that it should be perpendicular.
Perpendicular means to
Perpendicular to the spine.
spine.
It should not be angulated forwards. You can cut it down to the desired height.
Yes, sir.
I will put column illustrate because I don't want too much of extension. Already the lower and the cartilages are good. I don't want any lengthening. The main aim of the was to have correction of the crooked nose and the septum. So that we have achieved. Tip portion is normal as compared to his face.
Yes, sir.
So we'll put the column illustrate. See retractor. Because it was becoming difficult for me to place such a big septal extension graft. So the moment you put this domal creation suture,
Yes, sir.
the angulation of lower ala changes
Yes, sir.
to its favorable position. Shivaji, PDS. रोज सगळे लागले. So I have a really nice piece, straight piece for the columella strut.
Yes, sir.
So I have made a pocket. कुठं ठेवलं रे columella strut? Small tooth forceps. मिळाला.
So you already put the interdomal suture.
I have placed the just to have a. I'll cut it again.
Okay, sir.
Just to have the. You noticed it.
Yes, sir.
Just to have a dome position.
Okay.
अरे कुठे आहे PDS?
So in this little dorsal augmentation will be required.
No. I'll show you.
Okay.
No dorsal augmentation will not be required. Only the tip is at higher position.
Yes, sir. Because that is why it's looking quite
Yeah, yeah,
high.
yeah,
That is
yeah.
why I asked.
Cut. That's why I cancelled that idea of putting the septal extension graft.
Yes, sir.
Because it was looking too high for me.
Okay.
I want this tip to be wide.
Yes, sir. To match the dorsal.
Yes. कोण आहे? हाँ बदलू देत. Wash. So purposely I have kept this tip too wide. So let us put it back and let's see.
Yes.
Only thing, you cannot control the flaring.
Yes.
So that has remained as it is. Otherwise, everything has fall in place. You got my point?
Yes.
Yeah.
The space which is about the remaining, can we put the dice cartilage over there?
Madam, not needed actually. This supratip space will get filled
Yeah,
up.
supratip.
Yeah. This will get filled up with the soft tissue.
Okay.
In that dead space, nothing stays stable. So if at all you want to put something here,
Yeah.
this dead space is really challenging. So we'll just close it.
Okay. I think from above, if you will see,
Madam, that is not more. The dorsum height we have maintained. It has not at all reduced.
Okay. So over the years, like it will not cause any.
Yeah. हे घे. केव्हा करील नाही ना, PDS नच घेऊ. PDS नच घेतो. आहे भरपूर शिल्लक. Wash.
वो ऐसा कह रहे हैं कि एरियल व्यू में, हेलीकॉप्टर व्यू में इतना नहीं दिखेगा।
दिखाता हूँ, एक मिनट।
दिखाते हैं।
That's what he's saying, no? नहीं है वहाँ. Heading of the eyebrows. So much is there.
बीच में लेजर से उड़वाना पड़ेगी इसको। जो बीच के आईब्रो।
क्या टाइम हो गया?
तो उससे थोड़ा उसका चेहरा सही हो जाएगा। एक
What is
तरफ
the
थोड़ी
time?
बड़ी कर देंगे, एक तरफ को फिर से कैमोफ्लेज हो जाएगा। आईब्रो लेकर उसके बीच में मिली हुई है।
4 बजे 4 वाजता निघालो तरी फ्लाईट मिळायला काही अडचण नाही ना 6ची.
सर 4 बजे निकलूंगा तो भी 6 बजे की फ्लाइट मिल जाएगी ना?
हाँ मिलेगी, आप चिंता नहीं करो.
In this also you will put the stylistic sheets inside, sir?
Every case.
Yeah. Every in each and every case, even in septoplasty also.
Okay.
Cut.
Sir, in septoplasty, what is the advantage of stylistic sheeting? Septoplasty mein?
Again, the synechiae are less.
Okay.
Uniform pressure.
No need for putting suture.
एक तो लगाना पड़ता
I go.
है, नहीं लगाते, एक तो लगाते
हम थोड़ी लगाते हैं, हम तो शीट लगा देता हूँ.
हो जाता है, पीछे रिफ्लेक्ट हो जाता है पीछे. एक सिंगल में चलता है, सिंगल
आपको भेज देंगे.
सर हम लोग तो ना वहाँ जोधपुर में एक्सरे की फिल्म काट के लगाते हैं. हाँ, एक्सरे की फिल्म.
कई लोग इलेक्ट्रोड की काट के लगाते हैं. चाय तो पी लो. चाय पी के चल जाओ.
Sir, you've tried using that ready-made, those Teflon splints are available.
No.
You don't use that? You haven't used it?
No, I don't recommend because I put the Merosil. See the.
No, sir. In place of Silastic,
हाँ.
those ready-made Teflon ones are also available.
No, ready-made elastics are also available.
Okay.
They are costlier. This is very cheap.
Only 300 rupees.
नाकाला हाथ लाओ नको.
₹250 का मिलता है शायद. 250 भैया. नहीं आप मैडम एक्सरे फिल्म की बजाय आपका जो इलेक्ट्रोड रहता है ना, इलेक्ट्रोड के पीछे होता है उसको लगाए वो ज़्यादा अच्छा है.
So you make the surgery appear so simple and easy and inspiring to do. Otherwise, there are many people who will.
Yeah, it
looks very complicated.
Yes. See, it depends upon the approach, the plan. That's why I told you, now you should have a plan.
Yes, sir.
If you have a plan, then you can do it.
सूचर में कंफ्यूज कर
कट.
क्या कीर्ति सूचर के नाम में कंफ्यूज कर.
इंडियन वर्जन लिया था.
सिलिकॉन इथिलॉन घे रे, इथिलॉन घे. इथिलॉन हुडकून निडल होल्डरवर लाव मोठ्या. सिलिकॉन कुठे गेला अजून एक? हां हां इथे. हे काढ शिवाजी, हे काढ आता. विटॉम काढ. हां बाजूला घे, मला डोक्याला थटायला लागलंय. काढत चल, बॅगेत ठेवायला लाग. कॅमेरा राहू दे चालू, मी आता कॅमेऱ्याने दाखवतो. कट. हे स्टेरिलियम घे रे, जस्ट टू रिमूव्ह दोज मार्क्स. पटकन स्टेरिलियम घे. इट इज लुकिंग रियली नाईस. The axis deviation has totally gone. There is a wide tip.
Sir, we are not getting picture now.
No, sir. I know. अरे नको, तू नको रे, थांब जरा. माझ्या हातात दे. इतकं नाजूक राहायला लागते ना.
तो देखो 9 AM to 3 PM लिखा है मैंने उसके ऊपर, तो 3:30 पे ख़त्म करवा दिया. इतना कौन चलेगा टाइम से, जबकि शुरू हुआ था 9:45 बजे, तो 3:45 बजे ख़त्म हो जाएगा. हाँ, कल का अगर आज रखता तो सर की फ्लाइट छूटती 100%. नहीं, फ्लाइट तो क्या कल सुबह भी भेज देंगे, उसमें क्या है. अरे वो चाय लाए क्या, कहाँ गया वो? अबे लाओ ना चाय. आ गया. नहीं.
Sir, I'll show you with the endoscopy camera. काय म्हणलास? हां मेरोसिल पाहिजे ना त्याला हे घे So you can see this picture. You can see my
Yes,
picture.
sir. Yes, sir. The
Pre-op.
photo we can see.
Yeah, pre-op.
Pre-op, yes, sir.
ऊपर का लाइट लगाओ जरा
नहीं सो आया उसको लेजर ट्रीटमेंट दे रहे हैं ऊपर आ रही है
You can see this helicopter view.
Yes.
Yes, sir.
Good. The axis deviation has totally gone. In the lateral view, the dorsum is remaining straight.
Yes, sir. The lateral view we are not getting.
Are you getting the endoscopy view now? नहीं वो आपका
Yes,
बंद करो.
yes, now we are getting.
Very nice.
Yeah. I think you are not getting my view.
Now we are getting, sir. Yes, sir.
You can see that there is absolute
Yes,
axis
sir.
deviation has totally gone.
Yes, sir. Wonderful, sir.
Compared to this,
Yes, sir.
okay, good. And three-dimensionally it looks beautiful. It looks absolutely straight over here. Because what I'm showing you is the close-up view.
Yes, sir.
But if you stay back a little bit and see, it looks really nice.
So, Baki, your plastering will be remain the same, no?
Yeah, same. Plaster, merosil, everything remains the same. Yeah, dore card. I am putting the merosil, but I will not hydrate it. You got my point? I have put the merosil, but I will not hydrate it till I put the plaster. Or it will get slowly hydrated till the time plaster settles. Photo. Shivaji. ऊपर का लाइट बंद करो. वो डार्क है, तुम आ जाओ. Anyone with the lighter background? वो चला गया क्या? किशन चला गया? ये पकड़ो. होत नाही आहे का? प्लास्टर घे चल. थ्रोट सेक्शन मी लास्टला करतो. शिवाजी तू इन्स्ट्रुमेंट धुवायला लाग. तू थांबू नको इथं जा. शिवाजी जातो. किशन तू जरा इथे ये. त्याला इन्स्ट्रुमेंट धुवायला जाऊ दे. हां मला फक्त कट करून द्यायचे. कट केले. कर कर. बस प्लास्टर घे.
back निकालता हूँ